Welcome, everyone, and thank you for joining us today for Know Your NETs, the NET Research Foundation's 2024 Virtual Patient and Family Education Conference. I'm Elise Gellerman, CEO at NETRF. Our theme today is Hope in Action. Hope is both a noun and a verb. Hope is an optimistic state of mind. To hope is to look forward with desire and reasonable confidence. With neuroendocrine cancer, hope may mean the promise of research and the development of new treatments. It could mean the ability to manage symptoms and live a full and happy life. We want you to gain knowledge and hope from what you hear today from NET specialists and people with neuroendocrine cancer. We're excited that so many of you have chosen to spend part of the day with us. Registrants for this conference represent just about all 50 states and 15 countries. 58% of you told us this is your first neuroendocrine cancer education program. 36% are recently diagnosed in the past 1 to 2 years. We are especially glad you are joining us. If you have not yet watched NETs and NECs 101 by Dr. Aman Chauhan, you can view his presentation on our YouTube channel. I hope you've all checked out your virtual program booklet. You can find the link on the conference landing page or in the email we sent to you a few days ago. This program would not be possible without our co-sponsor, University of Chicago Medicine, as well as Novartis, RayzeBio, and Crinetics. Thank you to all of our sponsors. My co-chair for Know Your NETs is Dr. Xavier Keutgen of the University of Chicago Medicine. Dr. Keutgen is a surgical oncologist with extensive expertise treating neuroendocrine tumors. As the director of the University of Chicago Neuroendocrine Tumor Center, Dr. Keutgen leads a multidisciplinary NET team. Dr. Keutgen and his team have been longtime collaborators with NETRF, and we are always so grateful for their work on this conference. You will hear from Dr. Keutgen later in this program. So we start today with hope in action through research, from basic research through clinical trials. Our first speakers are Dr. Anna Greene and Dr. Dawn Quelle. Dr. Greene is NETRF's Director of Research. She leads our scientific programs and earned her PhD from Dartmouth College. Dr. Quelle is a co-chair of NETRF's Board of Scientific Advisors. She's a professor of neuroscience and pharmacology and pathology at the University of Iowa Carver College of Medicine. They will discuss the importance of laboratory research.
Hi, my name is Anna Greene, and I am the Director of Research at the Neuroendocrine Tumor Research Foundation. I'm happy to be here with you today to talk about NETRF and how we fund research so that we may have discovery in NETs through basic and translational research. NETRF has a core mission to support patients, families, and caregivers affected by neuroendocrine cancer. But in parallel to that, we also have another core mission to fund research to discover cures and more effective treatments for neuroendocrine cancer. NETRF is a leading global funder of neuroendocrine cancer research because we know this is how we're going to learn more about this disease so that we can learn how it starts, how it grows, and how we can better treat it. But why do we think research is important? Why do we think this is going to help patients? Because we've seen this work. So if we look at overall survival rates and how they've changed over the years, we can see great improvements. So if we look at the year of diagnosis of 2000 to 2004, we see that the 3-year overall survival for NET patients was about 50%. But moving to 2015 to 2018, we see that the overall survival increased to 85%. And so this is a significant increase, and it's attributed to different things, including improved diagnosis, improved classification of tumors, but also improved treatments. And so if we look at the right, we can see all of the NET drug approvals that have happened over time. And most of them have happened after the year 2010. And that correlates pretty well with improvements in overall survival. And so that's how we know that research works, and that's how we'll get to improved treatments for patients. So what are some of the NETRF contributions to basic and translational research? We're really proud of the research we've funded over the years, and some of the findings have been new mutations in NETs that have never been seen before, such as DAX and ATRX and PNETs. We've also funded work that's found new subtypes of NETs, such as a new lung NET subtype, the supracarcinoids. We've funded work that's led to next-generation radioligand therapy using isotopes actinium and terbium. We've funded work that's led to new NET models that allows scientists to better study this disease in the lab. We funded work that's validated new targets, such as UPAR, which is heading to clinical trial. And this is important because somatostatin is the common receptor that's targeted, and some patients don't have somatostatin receptors or express them heterogeneously. We're very excited to say that we've also funded work that's led to the first CAR T-cell therapy moving into the clinic this summer. But we still think there's more to come through research. We're very excited about areas like early detection. So how can we use biomarkers to detect the disease earlier so that we could perhaps cure it through surgery alone? We're excited about precision medicine. So how can we integrate molecular and genetic data about patients and their tumors to individualize treatment plans? Immunotherapies. These typically haven't worked as well for neuroendocrine cancer patients. But through research, how can we figure out how to harness the immune system to work against these cancers? Radioligand therapies. How can we improve PRRT to go beyond stabilizing disease to causing major regressions? And so we'll get there through research. And NETRF primarily funds basic and translational research. But research exists along a spectrum, from basic research to translational research to clinical research. Basic research is the building blocks of biological knowledge. This is where we learn biological fundamentals. So what causes the cancer to start? What's causing it to progress or metastasize? What are some new pathways to better treat the disease? Translational research is where we aim to take those discoveries from basic research and move them toward the clinic. This is where we might optimize a treatment. We'll test it in laboratory and animal models. We'll make sure it's safe and seems effective at this stage. And if it looks promising, it might move into clinical trial. And this exists in 3 phases: phase 1, phase 2, and phase 3. And each phase builds upon the next. Each phase looks at safety and efficacy of the new drug. And if by the end of the trials, the therapy is both safe and effective, it may be approved for use in humans. And so let's look at the NETRF portfolio and what our funding has looked like over the years. Since 2005, we've funded nearly $38 million in funding across 144 grants to 115 unique investigators at 74 institutions across 4 continents and 16 countries. So we are a large global funder of neuroendocrine cancer research. If you look at the pie chart, you'll see that in the blue and gray parts of the pie, about 92% of the pie is our funding of basic and translational research. A much smaller part of the pie, about 8%, is focused on clinical research that we funded. If you look at the table on the right, we also fund research across different primary sites. Because while we know that there are commonalities across disease, we know that there are also differences. And so we think it's important to fund research based on primary site. But we also think it's important to fund research based on multiple types of neuroendocrine cancer. And so that's part of our portfolio, as well as other types of research into rarer neuroendocrine cancer types, such as extrapulmonary neuroendocrine carcinomas, a very aggressive type of disease. And so how do we pick grants and how do we monitor them once they've been awarded? It first starts by issuing an RFA, which is a request for applications. This tells the scientific community that we're looking to fund grants and that we're ready to receive applications. So scientists will then send in their applications with their best ideas. We then send those applications out for a rigorous peer review process. So the applications go to scientific experts who review the applications and provide scores and comments on each application. We then meet for a peer review call where the scientific experts discuss the applications. They discuss the strengths and the weaknesses, and then they re-rank the grants at the end of the call. From there, NETRF can select the grants based on rankings as well as programmatic needs, and then they go to our full board for approval. But once the grants have been approved, our work doesn't stop there. We think it's very important to monitor the grant throughout its life cycle to make sure the grant is meeting its progress milestones. So every 6 months, grant recipients send in reports to us, letting us know of their progress. After the grant ends, we continue to receive outcomes reports, and this is a great way for us to track outcomes and impact of the work that we fund. We also have an annual research symposium every year where our grant recipients are required to attend and present their work. And so I want to end with a success story. So about a decade ago, we funded a group of investigators at the University of Pennsylvania to study CAR T-cell immunotherapy in NETs. This therapy had shown to be quite promising in blood cancers, but had been less successful in solid tumors. But we thought there was a lot of hope here, and so we gave funding to this group at Penn. So they worked very diligently to show that this has worked over time. They built a CAR T construct that worked well in mice, and this preclinical data has now allowed this work to move into clinical trial that's just started this month. And so we're very excited to see the outcomes of this work. And so with that, I want to thank our incredible research community who are in the lab every day to learn more about this disease. I want to thank our staff, our board of directors, and board of scientific advisors who make all of this possible. And of course, I want to thank you all for your time. We couldn't do this without you and your support. If you have any questions after my presentation today, feel free to follow up by the email address below. Thank you.
Hi, everyone. My name is Dawn Quelle, and I'm a professor at the University of Iowa in the Department of Neuroscience and Pharmacology. I lead the Cancer Genes and Pathways program in our Cancer Center, and I am part of a very large neuroendocrine tumor research team here, which I co-lead with Drs. Jim Howe and Yusuf Menda. And today I'm going to talk to you about discovery in neuroendocrine tumors through basic and translational research. I have no disclosures. So when we think about the journey each cancer patient navigates and the types of interventions at each stage, it ranges from preventative approaches to early detection, followed by diagnosis and specialized treatments, depending on the cancer type and stage, and ultimately palliative care and survivorship. My research primarily fits into diagnosis and treatment. What we're looking for is new biomarkers that will help define the tumor type and uncover new therapies that will best treat these tumors. So my work is both basic and translational in nature. What does that really mean, and how is that different from clinical research? Basic research is considered the foundation of medical discovery. It tells us how nature works and what causes diseases, and it's largely at the level of DNA, RNA, and protein. Now, translational research tests how those basic discoveries can be used to prevent, detect, and/or treat diseases. And it often is using preclinical models like animals. Now, in contrast, clinical research involves testing questions in people. That often will be clinical trials, but it also can be retrospective studies using tumor samples previously obtained. Importantly, we tend to think of this research continuum as a one-way kind of direction, but it isn't. The translational pathway from basic biological findings to the clinic is not unidirectional. Results from the clinic often support what we call reverse translation, where that moves science from the bedside back to the bench in an iterative process that actually helps patients faster. So in today's talk, I want to give you a flavor of this research continuum. And it's based on work from my lab where we've performed basic research using neuroendocrine tumor cell lines, translational research using mouse tumor models, and then working with clinicians to develop an early phase clinical trial in neuroendocrine tumor patients. Now, the major problem that my group is working on is to uncover new targets and therapies for NETs. Now, this is important because current drug therapies in NETs are not curative. Thus, we have a very strong need for effective therapies that will treat tumors that become resistant to the therapy. Now, as you know, NETs can arise throughout the body, but my group focuses mainly on tumors in the pancreas, lung, and small bowel. And I'm really lucky to be part of a large specialized program of research excellence, or SPORE team, at Iowa that is focused solely on neuroendocrine tumors. And our team is comprised of basic researchers like myself, as well as clinical experts like surgeons and endocrinologists and medical oncologists who treat NET patients at our very active clinic. And having both the basic and the clinical researchers working together is what really facilitates meaningful translational research. So this question that we're trying to solve right now is how to make neuroendocrine tumors and other tumors more responsive to immunotherapies, because we know that those are some of the best treatments for patients. And we focus first on pancreatic neuroendocrine tumors, or PNETs. Now, the premise of our studies is actually fourfold. The first is that clinical and translational studies have shown that anti-PD-1 immune checkpoint inhibitor therapy in clinical trials has not worked in PNET patients, despite the fact that those tumors have what we call good immune cells in the tumors, like T cells. Now, we've also done a lot of basic research, which has revealed that there are certain tumor-promoting proteins, like MEK and CDK4/6 kinases, that are overly active in PNET tumors. But monotherapies that have been tried in these patients that target CDK4 and 6 have not been effective. And then we know in other tumor types, like colon cancer, for example, or breast cancer, that MEK and CDK4/6 inhibitors promote immune cell activation, which is a good thing. And we have found in our studies that combining MEK and CDK4/6 inhibitors against PNETs actually stops their growth. So this brings me to a schematic that I hope illustrates the benefits of this combination therapy. It shows that abnormally high levels of MEK and CDK4/6 kinases, shown in yellow, cause increased PNET cell growth. And that is because they turn off a very important tumor suppressor called the RB1 protein. Now, what we and others have found is that combining inhibitors of CDK4 and 6, like the palbociclib drug, as well as mirdametinib, a MEK inhibitor, synergizes to fully reactivate the RB tumor suppressor in the tumors, stop tumor growth, and induce immune cell infiltration. So what I want to do is show you some studies that we've done in cells grown in culture as an example of our basic research showing how this combination works. Now, here we treated BON1 PNET cells with either no drug at all, either drug alone, or the combination in an assay that measures colony forming ability of the cells. Now, this combination was found to be most effective at reducing tumor cell growth as measured by fewer colonies and the size of colonies. Now, to translate that result, which was really exciting, towards patients, we moved into an animal model that was developed by our colleagues at Rutgers University. They made a MEN1-PTEN double knockout mouse, and those mice express very high levels of our target, CDK4, and those animals develop tumors by about 6 months of age. We expect to see better efficacy, including tumor regression, in the mice given the combo or the combination of drugs targeting both CDK4/6 and MEK. And this slide shows you that that prediction is true. So you can see that the combination acted synergistically to reduce that tumor size compared to either drug alone. And that's quantified in this graph, where that red bar is really small because that's the combination. And then the individual drugs are shown in the gray bars. Now, that robust level of tumor regression or shrinkage suggests that we activated anti-tumor immunity. So we quantified the tumor infiltrating immune cells in the vehicle controls versus the combination treated tumors, which are shown in red. And we found that the dual treated tumors had a much higher level of B cells and plasma cells within them compared to the controls. This was pretty darn exciting, and that's because in a lot of other human tumor types, infiltration of B and plasma cells correlates with much better patient survival. And it also correlates with the ability of those patients to respond better to immunotherapy, using checkpoint inhibitor antibodies that inhibit proteins called PD-1 or PD-L1. So if you haven't thought about this type of immunotherapy before, it is based on the fact that cancer cells express a protein on their surface called PD-L1, and that binds to a protein called PD-1 on the T cells, the green cells on the left. And that prevents your immune system from killing the cancer cells. So the use of PD-1 or PD-L1 antibody therapy blocks that interaction, and that unleashes the T cells to kill your tumor cells. And that's what we're hoping for. This led to our hypothesis that CDK4 and MEK targeted therapy will sensitize PNETs to anti-PD-L1 immunotherapy. And we tested this in the same mouse model that I introduced to you before. And we treated them with vehicle control in the open bar, with palbociclib alone in the gray bar, the anti-PD-L1 treatment alone in the red bar, and the combination in the blue. And you can see the combination caused near ablation or removal of the tumor compared to either drug alone. So in summary, we found some really exciting results here. First, that the combination of CDK4 and MEK inhibitors is effective against PNETs. And second, that we can sensitize PNETs to immune therapy by inhibiting CDK4 and 6 kinases. Now, we have a lot of future studies to do that are both basic and translational in nature, and they're listed here. But most importantly, this work has led to lots of conversations with our clinical colleagues, and we're working to develop a new clinical trial that's called a Phase 0 Window of Opportunity trial. This is where we take patients who are already scheduled for surgical resection of their tumors, and before the surgery, we want to give them a neoadjuvant therapy of combining the CDK4/6 inhibitor with the anti-PD-L1 therapy for just 5 weeks. And then what we will do is we will compare the pre-treatment biopsies with the post-treatment resections. And we will ask if the prediction is true that this therapy will actually increase immune cells within the tumors. And we'll also take blood draws before and after treatment to see if we can monitor that immune infiltration into tumor cells by simply looking at immune cells within the blood. And we hope that this will someday lead to better treatments for neuroendocrine tumor patients. So with that, I would love to thank the people in my lab shown in the lower left, as well as my colleagues at the University of Iowa shown in the right, who are all part of our large neuroendocrine tumor spore group, and especially our colleagues at Rutgers who've done that fantastic work in that mouse model of disease. And with that, thank you very much for your attention.
Thank you, Dr. Greene and Dr. Quelle. Scientists working in laboratories hope their research will lead to clinical trials to test new treatments. Dr. Dan Halperin will discuss clinical trials and research in immunotherapy for neuroendocrine cancer. Dr. Halperin is an associate professor at the University of Texas MD Anderson Cancer Center in Houston, and he's chair of the NET Multidisciplinary Conference there. He will be moving to Emory University in Atlanta in September to lead their NET program. Dr. Halperin?
Well, hi everyone. I'm Dan Halperin from MD Anderson, and today I have the pleasure of chatting with you about what I think is the most interesting and probably vexing topic in our field, which is immunotherapy in neuroendocrine tumors. A lot of challenges and a lot of opportunities. Here are my relevant disclosures. I think most importantly, we're going to talk a lot about investigational use and focus on clinical trials today. So for anyone who is going to fall asleep after the first slide, here's everything I'm going to say on one slide. The most important thing I want everyone to understand today is that the current state of the evidence really does not support standard use of immunotherapy for most of our patients with neuroendocrine tumors. There's a small minority of folks, I'll show you the special case, where people can fit into some tumor-independent indications for immunotherapy, but that's really a small minority. The second thing I hope to convey is that a deeper understanding of the tumor immune environment may offer us some insights and hopefully offer some new opportunities and new approaches. And then finally, we're going to talk just a tiny bit about CAR-T, which is right on the horizon of investigation. We think this is a really interesting novel approach that has some unique considerations. So as a trialist, we often think about clinical trials as enlightened empiricism. So let's talk a little bit about the moderately enlightened empiricism of the last 10 or 15 years or so in this space. So it actually was 15 plus years ago that Kjell Oberg and his group made the observation that immunity against tumors is somewhat impaired in patients with neuroendocrine tumors. And they actually observed circulating suppressive T cells and difficulty with expanding or activating the immune cells of the patient against some of the targets that were expressed on their own tumors. So they knew something was wrong. And actually, Professor Oberg has been one of the most vehement advocates for the use of interferon alpha, which is in many ways the original immunotherapy in clinical oncology. And you see here a couple of representative studies, again, almost 15 years apart, where folks have tried to see what, if anything, interferon might offer. You'll see a small randomized trial on the left where the addition of interferon couldn't significantly improve patient survival. And then to the right, you see a larger and more recent study nicely demonstrating that interferon and bevacizumab were similar in their effect on patients, but unfortunately not telling us what that effect might be, whether it was actually adding something compared to placebo or not. So it remains, as I say, a bit vexing, but we have yet to understand whether interferon as sort of a prototypical immunotherapy is adding much for our patients. And it's not something that is routinely used in clinical practice most of the time. And so I use that as a segue to start thinking about the cancer immunity cycle. And it's a complicated slide that we're not intending to go through in detail, but rather just to point out that folks much smarter than me have thought about how we can break down the process of developing an immune response against a tumor. And what I would point out is just that interferon nicely fits into one of those boxes. It fits into box 2 here. It helps with the presentation of antigens as folks are developing, ideally, an immune response. And so we can start to think about the various therapies that we might have at our disposal and that we might evaluate as targeting different elements of this cancer immunity cycle. And in fact, you may notice as we move through the presentation, I'll try and highlight how the various therapies that have been tested may target these different steps along the way as we try to turn on or unleash immunity against a neuroendocrine tumor. So here we have sort of the first, I would say, modern therapies of typical immune checkpoint inhibitors. And unfortunately, the title says it all. These have been rather disappointing and I would say in some cases heartbreaking. What you'll notice here, I've described the objective response rate and progression-free survival in a fairly large study of pembrolizumab. I would describe it as fairly similar to an expensive placebo. Response rates less than 5%, progression-free survival of 4 months and change, 3 to 5. This is right in the range of what we see in the placebo arm of a lot of randomized trials in this field. No clear relationship with expression of what we would think of as the target, PD-L1, and just generally fairly disappointing. And on the right, you see a similar agent, spartalizumab, targeting the exact same spot. That's the red box you'll notice in that reference tumor immunity cycle. And again, other than maybe a few folks with lung neuroendocrine tumors, not a lot of activity that was seen. And of course, we think of immunotherapy. If some is good, more must be helpful, right? So let's target 2 different nodes and combine ipilimumab and nivolumab. This was the DART study in the cooperative groups. And unfortunately, for patients with well-differentiated neuroendocrine tumors, you'll see here the lower intermediate grade, complete response rate was 0 and partial response rate was 0. So again, really not showing necessarily a lot of clear and convincing evidence for benefit in our patients now that we're hitting these couple of nodes together. But thanks to a number of projects that were supported by NETRF, we start to understand a little bit more about why that might be the case. And what I would point out is that those nodes that were just targeted with ipilimumab and nivolumab, they tend to be particularly helpful in patients whose tumors have pretty rich immune infiltrates, things we would call hot, if you will. And work led by Matt Kulke with a NETRF pilot award about a decade ago helped us to understand that these were actually, in fact, cold tumors with generally scarce lymphocytes or immune infiltrating cells, giving us some sense of perhaps why it might not have been quite so helpful to be pounding on the T cells that were just nowhere near the tumor, trying to get them to respond. Now, additional work supported by NETRF by Dr. Kim helped us to understand a little bit more about why these tumors may be so cold. And she helped us understand that, in fact, some of the proteins that make these neuroendocrine tumors so hypervascular may also contribute to exclusion of the T cells. And you'll see here on the left some data from humans showing us that, in fact, tumors with high expression of these pro-vascular proteins decrease the presence of T cells, and also the patients do less well. And shifting to the mice on the right, what she helped us understand was that if you block that process with an antibody, you can help increase immune infiltration and help mice live longer, better, healthier, and we hope more fulfilling lives. Interestingly, work by a totally separate group on the other side of the world suggested something very similar, which was that if we block the hypervascularity in a similar tumor model, we can increase immune cell trafficking, increase expression of that target PD-L1, and then block that PD-L1 to help mice, again, live longer, better lives and increase the immune infiltration. Now, this seemed like a really good idea, and we performed a clinical trial to see if combining VEGF blockade with a classic checkpoint inhibitor would be helpful. And unfortunately, the results were not what we were hoping for and expecting. We saw response rates on the order of 15 to 20%, and progression-free survival durations on the order of 12 to 15 months or so, quite similar to what we might have seen with a standard VEGF inhibitor like potentially bevacizumab itself. It's worth noting, of course, that this was a study that was based not only on the observations supported by NETRF that were seen over the last couple slides, but our own preclinical data that were supported at the same time as Dr. Kulke's work. Now, we weren't alone in going after these targets, and a couple of years later, Dr. Strasberg's group at Moffitt saw very similar results with an analogous combination of pembrolizumab and lenvatinib, so showing us once again, going back to that tumor immunity cycle, that even hitting these two nodes of trying to improve T cell trafficking through the tumor together with checkpoint inhibition with a PD-L1 or PD-1 inhibitor wasn't enough to help patients respond against their tumors. Now, from there, while I may have dashed everyone's hopes for a bit in demonstrating how ineffective what we thought reasonable immunotherapy approaches might be, let's pause for a moment and talk about that minority of patients where we may be able to find some benefit. And so what you'll see here is an old but I think relevant figure demonstrating the mutational burden of many different kinds of cancer from, I believe, the Cancer Genome Atlas. And what you'll find is that tumors that tend to be responsive to immunotherapy, tumors that tend to be hot with rich T cell infiltrates, all actually congregate over on the right side of the left-hand figure. So cancers like melanoma, lung cancer, stomach cancer, tumors where the mutational burden is high, we tend to see more responses. And we think about that as being because there are more targets that are new or neoantigens for the immune system to respond to. Now, I've highlighted in red the neuroendocrine tumor patients. You'll see they were called carcinoid in those days. And you can see that actually it's a log or two less in terms of the tumor mutational burden. And this is something that's been reproduced several times. That includes in our own data over on the right, just referencing that bevacizumab and atezolizumab study. But what I use those data to illustrate is not just that the tumor mutation was generally low, but that there were a few patients, you'll see that high blue dot and a couple of others, above the classic 10 mutation per megabase threshold that we think of as independently predictive of potential benefit from immunotherapy. Now, the reason we think that is there was actually a study of pembrolizumab in patients with tumor mutational burden over 10, demonstrating a reasonable response rate in the 30% range, but I think more importantly, that patients whose tumors responded tended to do very well for prolonged periods of time. And it was actually difficult to observe how long the patients would live because they would do so well. So the point of that is just to illustrate that there is that small fraction of patients, probably further into the course of their disease than those studied in that left-hand figure I showed you a minute ago, who may have an elevated tumor mutational burden and may benefit from immunotherapy as a result. And that is a tumor-independent or tumor-agnostic indication for pembrolizumab, rather than one specific for patients with neuroendocrine tumors. Now, finally, let's turn to CAR-Ts. And these are relatively novel for us in the solid tumor space, but really the concept here is that we will engineer T cells so that they target something very specific. And so in order to do that, we're going to need to figure out what they should be targeting. Now, I'm going to distill years of someone else's work into a single slide here for the sake of time, but this is work by Professor Sinjun Hua at Penn, who was supported by an Accelerator Award in 2018. While I'm not showing the figures of figuring this out in llamas, apparently, originally, they were able to determine that there was an actionable target, CDH17, that was overexpressed on NETs and potentially targetable with an engineered T cell. And in fact, much of the work that he describes is in the process of engineering the targeting of the T cell specifically to CDH17. Now, what you'll see here in humans on the left is that surface expression of the target, the CDH17, and what's worth remembering about this as a target is that normal cells don't have it on their external surface where it can be seen by the immune system, but rather it tends to exist to hold cells together and therefore is privileged or hidden from them. And in that pie chart, what you can observe is that it was roughly half of the neuroendocrine tumors surveyed at that time that demonstrated expression, although I believe that has a predilection to tumors in the gut, which will bear out in a moment. What you see over on the right, though, is the really cool stuff where they engineer the T cell, and then you start to see in the cool colored photomicrographs the purple immune cells finding their way into the tumor, but not the normal intestines or small bowel or colon, and not really having an effect on the normal tissues, just the tumor. And then in those curves, you can see that the T cells are actually expanding in the blood. That's the lower right. And I'm just going to remind you of the difficulty that patients' T cells had expanding to tumor antigens back in the very first slide. And then in those tumor growth curves above, you can see the way that they were able to kill the cancer, and we would hope prolong the mice's lives with these CAR-Ts. And so this is quite exciting, and in fact, the CAR-T was acquired by a company that is right now opening a clinical trial of this drug. Now, these CAR-T cells and these studies can be a bit complicated. We have to be very careful about monitoring for appropriate toxicities, and they're rather complex to do. But it's really exciting to see something entering the clinic, coming truly from the bench to the bedside. And so as I alluded to, what you can see here is that after the dose level escalation, there's an expansion into patients with a few different tumor types, including midgut and hindgut NET, as I said, because this particular target has a predilection for the gut. So we're really excited to see what we can learn and hopefully help folks with this new therapeutic approach. So, as I said, for anyone who zoned out for the last 10 or 15 minutes or so, that's fine. Here's all the main points again for you. So I hope that we've convinced you over this time that immunotherapy is really not a standard part of the management of the vast majority of patients with neuroendocrine tumors, other than some very specific cases that we discussed. But that a deeper understanding of what's happening in these cancers hopefully helps us understand why some things may be more helpful than others and suggest new approaches for us to take. One of which is CAR-T, which, as we said, is about to launch, looking at CDH17 targeted CAR-T cell developed out of work supported by NETRF. And we hope that this unique approach will be helpful for patients, but only time and research will tell. And with that, I just want to thank you all for your time and attention. And again, my sincere gratitude to NETRF for the invitation. Thanks.
Thank you, Dr. Halperin. If you're interested in clinical trials, there is a NET Trial Finder on NETRF's website, and you can find the link in your booklet. NETRF funds research around the world, and we want to bring an international perspective today. Dr. Jules Derks is a pulmonologist at Erasmus Medical Center in the Netherlands. He is also a NETRF grantee. Today, he will discuss NET advances in Europe.
Good afternoon, everyone. My name is Jules Derks. I'm a pulmonologist in the Netherlands at the Erasmus Medical Center, and I'm a fellow in thoracic oncology. So I mainly treat patients with lung cancer and also patients with neuroendocrine lung cancer. And today I will give a presentation on the advances in NETs from a European expert perspective. I have no disclosures. So first of all, I would like to talk with you about the classification of lung NETs that we currently have. So lung NETs are defined as neuroendocrine neoplasms of the lung, and we separate these into atypical and atypical carcinoids. And this is what you see when you look at the current classification. On the left, you see the carcinoids, and on the right, you see the neuroendocrine carcinomas. And when a pathologist looks under the microscope at these tumors, he or she can see different morphologies and a different rate of growing tumor cells, so mitosis and necrosis. And based on a certain classification, it can separate carcinoids from neuroendocrine carcinomas. And this separation is reflected in clinical practice by the behavior of these tumors. So we know that carcinoids can have an indolent behavior for a while, but they can become very aggressive and metastatic. The atypical carcinoids are generally more aggressive from the beginning, and the neuroendocrine carcinomas are really aggressive carcinomas from the beginning and metastasize quite often. When we look at the incidence of this disease, at least in the Netherlands, we know that about 2% of all lung cancers are from a typical carcinoid. So 0.2 to 0.4% is from an atypical carcinoid, and 3% is from LCNEC, but I won't discuss that further today. As I've told you, I'm a pulmonologist, and I treat patients with neuroendocrine lung disease. And I treat them both at a local stage and a metastatic stage. And here you see the overview of how we treat patients in Europe with local disease neuroendocrine tumors. Mainly, the treatment consists of surgery, where the surgeon removes the primary tumor, but also involves lymph nodes. And afterwards, a period of observation is followed, where we follow up our patients to see if any recurrences occur. What we do know from this time after surgery that about 1 in 10 patients unfortunately develop a relapse. And this is affected by the morphology, so if it's a typical or atypical carcinoid, if any lymph nodes are involved, or if it's a larger tumor. From a study that we did recently, we found that about 50% of all relapses occur within 5 years, so the median is 5 years. But in up to 10 years, the disease can come back, so patients need a very long follow-up after surgery. And where should we look then for relapses when we follow up these patients? It's mainly in the lungs, in the liver, in the bones. So a CT of the thoracic cavity and the liver is very important. And there is an important difference here between Europe and the States. Here you see the follow-up scheme after surgery for patients with local disease they had surgery in low-risk disease, so a typical carcinoid, no lymph nodal involvement, and a small tumor. The ENET advises very frequent CT scans, while the ESMO guideline advises few CT scans, but for a very long period, so up to 25 years after surgery. And this is different in the States, what I found, that the NET advises no follow-up at all. And as a clinician, we need to think of what is the benefit of following our patients for such a long period, and what is the risk of radiation exposure to the patients when you follow them up for such a period. And we are currently looking into this to give better advices in the future. So the NANET advice comes from several studies that have evaluated large cohorts of patients who had surgical resected disease. And they found that, again, this atypical carcinoid, lymph nodal involvement, and larger tumors, these patients are at higher risk of death after surgery, but also of disease coming back, which you see here on the right. However, most of these studies have only followed the patients for a certain period. Here you see a follow-up of about 5 years. As I've shown you previously, we need to follow them up longer to really see we can use these clinical classifications to provide a good follow-up of the patient. There are some new insights as well. Here you see an overview of a study that has been recently published in Europe, where they evaluate about 260 patients with lung carcinoids, and they asked 6 pathologists to look at all these different tumors. These pathologists often did not agree on if it was a typical or an atypical carcinoid. Moreover, when they then asked a computer to evaluate all these slides through a deep learning process, they did not find an improvement of the prognostication of these patients, so no better split. So maybe we need new ways to enable a better prognostic prediction of our patients post-surgery. Personally, I really believe in the added value of molecular biomarkers, so tumor-specific biomarkers, and you can see an overview of these here. On the left, you see the standard staining, and then again, we see a Ki-67 staining that we utilize also in other patients with neuroendocrine tumors, and the marker OTP and CD44. And based on the evaluation of more than 500 patients with a very long follow-up, so you see the black dot there, it's the 10-year follow-up, we could separate these groups into a high-risk and a low-risk patient group. And these low-risk patients group, in fact, only had 4% a relapse after 10 years of follow-up. So I think we can improve our follow-up prediction in patients utilizing these biomarkers in the future. So to come back, local stage disease lung NAN, mainstay of treatment is surgery. We need to follow up a certain amount of patients, but we need to better define which patients to follow up. And this may be done by integrating biomarkers and these clinical characteristics that are already known. Then I would like to add one paper as well, which has been recently published, and that showed if I see a patient in clinical practice that I cannot perform surgery on, or I cannot refer to the surgeon, then there might be other ways to treat the tumor if it has not metastasized. One of these is external beam irradiation, so radiotherapy. And this can be applied in patients with a poor lung function who are frail. And this has shown a very nice local control rate at 9 years of about 90%, so 9 in 10 patients. The next part I would like to discuss with you metastatic lung NANs. And one of the important things here is when we look at the incidence of patients with lung NAN, we see that there's about a 35-fold difference compared to the most common type of lung cancer, which is non-small cell lung cancer. Well, when I then look at all the clinical trials currently recruiting patients, there is a 300-fold difference. So 3 in LNANs at the moment and more than 900 in non-small cell lung cancer. And this is reflected in all the treatment options that we have in clinical practice. Here again, you see this overview of typical carcinoid and atypical carcinoid separated, where we can see that patients with a typical carcinoid have metastatic disease in about 1 in 10 patients. At 5 years, about 80% is still alive. At 10 years, this is about 60%, and that most patients have somatostatin expression. In atypical carcinoid, 1 in 5 patients have metastatic disease at presentation. At 5 years, about 50% is still alive. And at 10 years, this is only 20%. And here on the right, you can see an overview of a Kaplan-Meier curve, which shows the amount of patients still alive over time. And you can see that this is more rapidly decreasing for atypical carcinoids compared to typical carcinoids. When we then look at treatments, what kind of options do we have? So the standard advised treatment for typical carcinoid Europe is a somatostatin analog. And recently, a phase 3 trial has shown a non-statistical significant difference in the time that the patient did not have a growth of their tumor compared to non-treatment, so placebo. Unfortunately, this study did not accrue sufficient patients to really give a strong advice. In atypical carcinoid, we have the RADIANT-4 study. There, patients were treated with everolimus, and it has been shown that there was a difference of about 5 months in this progression-free survival compared to placebo. Both these drugs do not show a strong reduction of tumor growth, so the objective response rate. It was 1% for RADIANT, and in SPINET, it was about 14%. When we then look at all the trials which have been done over the past few years, only few have been able to really change the treatment of patients, and only one, this RADIANT-4, has been approved by the European Medicine Agency. And I would like to explain a bit more about these different treatments. So somatostatin analogs, it's based on the SPINET trial. Their patients get injected lanreotide, which is a somatostatin analog that attaches to the tumor, and there, upon attachment, it induces apoptosis, so cell death, and it makes sure that the tumor doesn't grow as quickly anymore. We also have peptide receptor radionuclide therapy, PRRT, which actually has been developed at Erasmus several decades ago. Using this treatment, again, the same receptor, so the somatostatin receptor, is utilized. And on this somatostatin receptor, there's another drug attached, lutetium-177, which is very radioactive. And once you inject this into the patient, it goes to the tumor, and there it releases this radioactivity. It causes DNA damage and cell death. And this shows a reduction of tumor growth in about 1 in 3 patients. And based on retrospective studies, the tumor growth declined in about 18 months. So PFS of 18 months has been observed. So this is somatostatin targeted therapy. Then we also have non-somatostatin targeted therapy. Here we can find the tyrosine kinase inhibitors, or the protein kinase inhibitors, such as the RADIANT-4 trial, which I discussed using everolimus. But there have been several drugs been tested also in neuroendocrine tumors, but unfortunately none have been approved at the moment for lung NETs. Cabozantinib is a drug of interest, and I will discuss that a bit further on. And then, of course, we also have chemotherapy. So the main chemotherapy commonly used, at least in my clinical practice, is capecitabine temozolomide chemotherapy, which shows a reduction of tumor growth in 1 in 5 patients, so that the tumor really regresses. And it also causes DNA damage, and this capecitabine makes sure that the temozolomide is a bit more effective. So when we look in Europe at the current treatment algorithm, here on the left again we see the typical carcinoids, so the more slowly growing kinds of carcinoids. And the general advice is to either observe or start somatostatin analogs if these are somatostatin positive tumors. For atypical carcinoids, the more aggressive ones, we are advised to directly start with everolimus, and afterwards you can switch to temozolomide-based chemotherapy, and maybe afterwards PRRT. And this, in fact, is not that much different from the advices I found back in the States, which first line is also everolimus, and afterwards chemotherapy or this PRRT. Important differences maybe are found in the future, because both in Europe and in the States there are 2 current trials ongoing. One is the LEVEL trial, which evaluates PRRT compared to everolimus in patients who have a somatostatin positive tumor. Similarly, this trial is ongoing in the States, and it's called the Alliance A021901 study. And hopefully in the next few years, this will provide us the answer if we should initially treat our patients with everolimus or straight away start with PRRT treatment. The other drug of interest is cabozantinib, which I just recently mentioned. This is based on the CABINET trial, which has been presented by Chen at the ESMO 23, and it separated a extrapancreatic NET cohort and a pancreatic NET cohort. And in this extrapancreatic NET cohort, they found a difference of progression-free survival of about 5 months compared to placebo. In total, 1 in 20 patients showed a reduction of their tumor growth, but it came at a cost of more toxicity. Only a few days ago, Ipsen sent out a press release that they might be interested to get this drug EMA approved, and we still need to await if this is possible. So on the next slide, we'll talk about new developments in the lung NET field, and it's based on molecular subtyping. So as I've shown, you have these 2 lung carcinoid types, typical and atypical carcinoid, but based on the new molecular findings, so genomic evaluation of these tumors, we in fact see that there might be 3 or 4 types, and these can be separated into A1, A2, and B, but also the supracarcinoid groups, really nicely highlighted by Alka et al. And also by Lada et al. In a separate cohort. Recently, I've developed a panel, so immunohistochemistry panel, that you can stain the tumors, and we're trying to see if we can compare these molecular patterns that we identified with the staining patterns to apply this in clinical practice. And interesting here is that we found also in a very large cohort of lung carcinoids, so more than 400, that these subgroups, at least this A1, A2, and these B, express somatostatin receptor type 2 differently. compared to the A1s. Well, this A1 subtype expresses more highly DLL3, which is a new target for drug treatments. So DLL3 is a new potential target of treatment in patients with neuroendocrine cancers. And it's based on a study in lung cancer where they recently shown a very long effect in a very resistant type of cancer, which is small cell lung cancer. This drug works by activating the T cells, so the immune cells, and attaching them directly to the cancer cells. And thereby, the immune cells again recognize the cancer cells and start to attack them, and they start to degrade. So combined, all these new drugs and new studies can be combined into this figure, which on top you see the lung carcinoids again, so the typical and atypical carcinoids, and below you see the different molecular subtypes. We see the A1, the A2, and the B, but there might be also these supracarcinoids. And based on the molecular panels, in the future, we may need to treat our patient differently and more molecular based. And here you see such an overview of which I envision for the future. So hopefully in the future, patients with A1 might be treated with a BiTE treatment. A2 and B should be treated with PRRT and the somatostatin analogs, while the supracarcinoids might be more vulnerable to immunotherapy. And overall, there everolimus and cabozantinib come in as well. So the future of lung NAND treatment might be personalized treatment, but we need a lot of new studies for that. With that, I would like to thank you for your attention, and of course, the group which I'm working in, I perform my research as well. Thank you very much and have a nice day.
I would say the thing that gives me the most hope is research. It feels like something new is coming out every day. There are new solutions. And, I just think about the people who work so hard to do that research and slog through the paperwork and, get it through clinical trials just to get it to me. And then who knows what's going to happen tomorrow. I mean, it's just so exciting.
The thing that gives me hope is the advancement in medicine that we have, just because I've spoken with NEC patients where they experienced this over a decade ago. There were not any clinical trials that were available for the patient population. And now we have genomic testing where this offers us additional targeted therapies where these lines of therapy would not be an option to us as well. With all these advancements in science, I do believe that patients like me, where our options in terms of standard of care treatments is very slim, but being able to have immunotherapy, targeted therapy opens up additional options for us as patients and just hope.
I think what really gives me hope is honestly the stuff outside of just what my oncologist tells me. So there's a quote that I love from a doctor named Donald Abrams, who's an integrative oncologist at the Osher Center at UCSF. And his quote is that cancer is the weed we need to tend to the garden. And I love that quote because it sums up for me everything about hope. And it sums up how I go to my oncologist and I do chemo, radiation, surgery, immunotherapy, basically the core four, as I call them, to kill the bad stuff in my body. But killing the bad stuff in my body doesn't make me better long-term, right? What makes me better long-term is all the things I can do to improve myself as a person and to help my body function better.
Advancements towards like clinical trials, chemo, combined with like PRRT. So I really think there's a lot more focus and attention around neuroendocrine and just a lot of space for growth, for discovery of new treatments.
As a caregiver, I remain super hopeful because I know that there are tons of researchers and doctors out there working to help find a cure to this disease.
Many thanks to our NET Thrivers for sharing their experience and hope. You will hear more from them throughout the program. Now we're turning to hope in action through the collaboration of NET specialists. You will learn more about treatment sequencing, always a popular discussion, and see a tumor board where NET specialists consider treatments to develop a plan for a patient. Our co-chair, Dr. Xavier Keutgen, and his University of Chicago Medicine colleagues, Dr. Andy Liao and Dr. Osman Ahmed, will discuss combining and sequencing novel therapies. Then for the Tumor Board, they will be joined by NET specialists Dr. Mark Lewis, Director of GI Oncology at Intermountain Health and a NETRF board member, Dr. Heloisa Soares, leader of the NET program at Huntsman Cancer Center at the University of Utah, and Dr. Aman Chauhan of the University of Miami.
Good afternoon and good morning, everyone, wherever you are, and thank you very much for joining the NETRF virtual conference. I will talk to you today about treatment sequencing, and in particular, I will talk to you about the role of surgery and PRT in the treatment sequencing of neuroendocrine tumors. So these are the NCCN guidelines from 2018, but they haven't changed significantly. These guidelines are used by clinicians, and as you can see here, patients with metastatic neuroendocrine tumors, if complete resection can be achieved, as you can see here, that is the recommendation and it should be done. However, things get a lot more complicated when complete resection cannot be done surgically. First-line therapy is usually long-acting octreotide, and then patients eventually progress on this therapy, and then you have a whole long list of all kinds of different systemic as well as local regional therapies. And you can see here the NCCN guidelines say or. So really it's unclear what needs to be done first, and depending on what center you are and specifically from one patient to another, the recommendations may change. Therefore, it's important to really try to understand what therapy is better for what patients. Systemic therapies that comprise long-acting octreotide as first-line therapy, but also targeted chemotherapy, and PRT are really an important milestone and a cornerstone of metastatic neuroendocrine tumor care. But local regional therapies like surgical debulking, liver-directed therapies with bland embo, radio-embo, or chemo-embo, as well as liver transplant, albeit that's pretty rarely, are also very important. What therapy to use when? Really depends on multiple things, including overall tumor burden, tumor distribution, patient wishes, symptoms, and comorbidity, and also access to therapies. So if the tumor is mostly limited in the liver, but it's not too much tumor, surgical debulking can be offered. This is mostly in the skeleton. Surgery probably is not the best option, so probably a systemic therapy would be better. And then not every patient has access to a high-volume surgical debulking center, experienced IR doctors, or even PRT in certain regions, although that's getting better and better. I want to talk to you today specifically about PRT and surgical resection and debulking, and try to explore the relationship between these two therapies and how they can help each other. So metastatic pancreatic neuroendocrine tumors, or as a matter of fact, all neuroendocrine tumors, are often metastatic to the liver. You can see here about 50% of both PNETs and small bowel nets. And as you can see here in that graph, overall tumor burden plays an important role, especially liver tumor burden in terms of survival. So if you have greater than 50% of your liver that's replaced with tumor, your survival is significantly worse than if you have less than 10% of your liver that's replaced with tumor. The number 1 and 2 causes of death in neuroendocrine tumor patients are liver failure due to overwhelming liver tumor burden. So that's a majority of cases. And then some people get into complications and potentially deadly complications from primary tumors, especially when it's designed as small bowel like obstruction, perforation, or bleeding. Now, you've seen me talk about this before, but why do we offer surgery for liver metastases? And why do we do surgical debulking? Well, surgery is the only potential for cure, although that happens rarely when you have liver metastases, so the tumor is spread outside of the vicinity of the primary tumor. It is quite difficult to cure patients because even if we take out everything that we see within the liver, there still is a chance of recurrence through micrometastatic disease. So what we can't see, we can't remove. But we have a handful of patients certainly that have been cured. If there really only are a few lesions in the liver and there's nothing else, removing them can cure you, which is why the NCCN guidelines recommend to do that. There's a survival advantage over neurosurgery in retrospective studies. So by resetting the clock, so removing most of the disease, greater than 90 or 95% most of the time, because these are slow-growing tumors, we sort of allow many years until the tumor grows again to the same size than it was before surgery. So that gives you effectively years in your life bank. Surgical debulking definitely improves symptoms. There's no question about this. And I'll invite you to look at our tumor board that we are going to present later during this NETRF session as well. And you'll hear about some of these cases. And we can achieve major tumor burden removal with surgery, which is usually not the case with systemic therapy or even liver-directed therapies that are non-surgical. And then complications are much decreased, especially in high-volume centers, as we get better and better at doing these cases. Lastly, surgery may make systemic therapies work better, and this is the loop back to PRT that I'll talk to you about in a few minutes. So you've also seen this maybe before, but we look at where tumors are within the liver. Are they on both sides or on one side, uni or bilobar? Here, the tumors are in dark. We look at the relationships of these tumors to inflow and outflow, and we look at individual tumor size in order to understand how we do the resections, but we always try to cut just the tumors out or to ablate them without taking major structures, inflow, outflow, or major parts of the liver in order to prevent complications in liver failure. There are cases where we definitely don't want to operate, so it's important to know when to operate and when not to operate. Those are when you have a lot of liver tumor burden, when you have bad carcinoid heart disease that usually needs to be fixed first before you take patients to the operating room for the liver, portal vein thrombosis, poor performance status in highly aggressive tumors like G3 tumors or polydifferentiated neuroendocrine carcinomas are generally not good candidates for a resection. And many studies, all retrospective, over thousands of patients have shown that surgery can be done, that it can be done well. This is our series that was published last year, and we showed that the rate of complication is less than 15%, the major rate of complications, and that the liver function can completely be preserved after these type of cases. That's on the right side here. Specifically, the one thing that we noticed mostly is the more tumors you debulk, in this case greater than 25 in purple, the lower your platelet count drops within the first few days, but that, as you can see here, recovers relatively quickly within 5 days. It's true also for the liver damaging enzymes like ALT and AST. You can see they spike up the more you resect, but then they normalize within 5 days. So liver failure is not a problem with these type of operations if it's well done, and patients recover very well with low rates of complications. We even have shown in the past that if you have surgical debulking, when you have extrahepatic metastases, so let's say skeletal metastases, you can see here the dark curve here shows that we still actually have an improvement in overall survival compared to no surgery, which is the blue curve. But it's not quite as good if you have extrahepatic metastasis than if you don't, which is the green curve. But let's not kid ourselves and let's be honest, right? All of the surgical debulking data that I showed you is retrospective, meaning there's no comparative studies that basically compares surgical treatment to another treatment. So even though it's definitely beneficial, we think we don't know how much better it is than any other therapies. The truth is also that surgical debulking does require a certain expertise and generally is only available within multidisciplinary centers. So some patients may not necessarily get access to it, or their disease may have progressed too far along without them having the opportunity to see a surgeon. And therefore, once they see a surgeon, there may be too much tumor burden in the liver to be debulked. And then the sequencing of when to use surgical debulking, especially when compared to other therapies, really remains unknown. And this is why it's so important to continue to study this field, even though surgery has been used for a long time. And especially it's important to study surgery in relationship to other therapies. And one of these other therapies is PRT, right? So theragnostics stands for therapy and diagnostics. You've heard about this. It's essentially the principle of using a targeted molecule with a linker and a medical radioisotope to either make things light up for diagnosis or to destroy it when you have beta or alpha particle that are combined with these targeting molecules that then targets the tumor cells directly. The oldest form of theragnostics is actually radioactive iodine, which has been used for thyroid cancer for over 60 years. And you know that somatostatin receptors are expressed in well-differentiated neuroendocrine tumors and therefore represent an ideal surface molecule for theragnostics or PRT to work. And Lutathera, which is a beta-emitting theragnostics that we use all the time, actually is comprised of either gallium or copper-64, 68 for diagnosis, or lutetium-177, the beta-emitting particle that you can see here in the chelator area. And then we have the DOTA, which is really the linker that links that chelating area to basically octreotide that then targets the somatostatin receptor on the cell surface. And PRT has basically, as you know, been shown in the NETR1 and recently in the NETR2 trial, which Dr. Liao talked about, to significantly improve progression-free survival. But even though injected 4 times, total of 800 millicuries over 8 months, it is certainly not curative. And if you look at this European data here, you can see that the partial response or complete responses are still less than 50% in most cases. Pancreatic neuroendocrine tumors tend to have a little bit higher rates of response, and this is one of the things that my lab has been studying. And without going into too much detail, what we essentially showed is that MEN1, which is a common mutation in pancreatic neuroendocrine tumors, actually predisposes a more radiosensitive phenotype. So those cells actually cannot repair DNA as well because they have a defect because of the MEN1 loss of function into the DNA repair capabilities, and therefore radiation, like beta-emitting radiation given with PRT, makes these cells die more rapidly. And we've seen this recently in a study that's not being published, but will be published very soon, where you could see here, we compared MEN1, DAX, and ATRX mutant tumors. They are all involved in DNA repair, these 3 genes, in the blue line. And then the wild type, so those without a mutation, in the red line. These are all patients that underwent PRT. And you can see that those with the blue line, so that had these mutations, tend to have a longer progression-free survival, especially when you look at pancreatic neuroendocrine tumors here, which is the second graph. You can see over 20 months difference in terms of progression-free survival. So PRT works better if you have these mutations. Now, when we look at overall what has been known about all these systemic therapies that we use for patients with metastatic neuroendocrine tumors, especially to the liver, very few actually give us information on how well they work with liver disease. And remember, liver disease is very important in terms of prognosis long-term for metastatic neuroendocrine tumor patients. And so really, we ought to study further how these therapies can work in order to stabilize and possibly decrease the liver tumor burden. Now, there's a little bit of data from the NETR1 trial and a sub-analysis that has shown that Lutathera, so PRT, works better when you have smaller tumors that are less than 3 centimeters within the liver. And there's also European studies that has shown that if you resect the primary tumor in those patients that undergo PRT, those patients actually tend to do better and live longer. So at the University of Chicago, we recently studied specifically this question is, does surgical debulking improve responses to PRT? I showed you that MEN1, which is something that we can't change, either your tumor has a MEN1 mutation or it doesn't, improves progression-free survival after PRT. But is there something we can actually do to make these progression-free survival curves better? And this is a manuscript that's been accepted and will be published very shortly. So here we looked at almost 100 patients, of which a third did not undergo surgery and 2/3 underwent surgery. About 43% had only their primary tumor removed, and 57% had surgical debulking of the liver in addition to their primary tumor. And as you can see here, those that had the primary tumor resection versus those that didn't have surgery, the progression-free survival after PRT, so all these patients had PRT, was not really significantly different. It was just a few months better. But when we looked at those that underwent surgery versus those surgical debulking versus those that didn't, you can see here that the progression-free survival after PRT is greater than 1 year. So you gain 1 year after PRT or more in those patients that underwent surgical debulking. When we ask our question why that is, we started calculating tumor volumes before PRT in the surgery and the no surgery group. And we found, thank God, as a surgeon, I have to say, that the tumor volumes in the surgical group were significantly lower, as you can see here in blue here in the right lower corner, compared to those that did not undergo surgery. So meaning we removed a bunch of tumor when we actually did the operation. But when we looked at the graph, we identified 138 milliliters as sort of the ideal tumor volume in this particular study that made the biggest difference in terms of survival after PRT treatment. So those with a lower tumor volume that underwent PRT had almost 21 months, so almost 2 years, benefit after receiving PRT than those that had a higher tumor volume. So we therefore concluded that probably surgical debulking decreases tumor volume and therefore improves the response rate to PRT. So when we talk about the sequencing, we think that perhaps surgical debulking should happen prior to PRT rather than after, because it would allow PRT to work better with a lower and smaller tumor volume. So in conclusions, we showed recently that research is really important to identify variables that predict PRT response. I showed you a little bit about the MEN1 mutation status that we showed in the lab and then confirmed in our clinical cohort. We also showed that patients with metastatic neuroendocrine tumors may benefit from tumor reduction prior to undergoing PRT. And then we also showed that reliable prediction calculator for PRT can probably be developed. We're going to work on this over the next year. And that PRT calculator may include pathologic variables, somatostatin receptor expression, but also genomic things like MEN1 mutations, DAX, ATRX mutation, and also volumetric variables, lower volume versus higher volume. And the ideal situation would be that in the future, you have as clinician, we have a website where we can put all kinds of variables and then we can know, how well you're going to respond to PRT and whether PRT, therefore, is the next best solution for you or whether another systemic therapy may be better. So surgical debulking definitely may complement PRT rather than compete with it. And therefore, we conclude that surgical debulking and systemic therapy, in particular PRT, and we're studying other systemic therapies at this point as well, are really going hand in hand. It's not one versus the other. It's really trying to understand those patients that can undergo debulking, should undergo debulking, but when should it happen? And we think that at this time, at least with the data I've showed you, it's better that it happened earlier in the course before PRT happens than later. So with this, I'd like to thank you and NETRF and all these associations and foundations that have funded some of this research, as well as my collaborators. This has been really an exciting few years for us. I think research is really taking off all across the country and the world, and NETRF has really played a hugely important role in making sure that this research happens. So thank you very much to NETRF, and thank you to all of you for being part of this meeting today, and I hope to see you soon.
Hi everyone, I'm Andy Liao from the University of Chicago. Today I'll be talking about combining and sequencing novel therapies in neuroendocrine tumors with an emphasis on systemic therapies. We'll start by talking about the evolving role of lutetium dotatate PRRT, which is Lutathera, including data supporting its use in first-line therapy, as well as the optimal sequencing and combination approaches for PRRT. We'll then talk about alpha PRRT, and finally, novel targeted therapies with a focus on cabozantinib. So when we think about systemic therapies for well-differentiated neuroendocrine tumors, we're talking about somatostatin analogs, which include octreotide and lanreotide, PRRT, which includes lutetium dotatate or Lutathera, or alpha particle PRRT. Targeted therapies, which include everolimus, sunitinib, and cabozantinib, and then traditional cytotoxic chemotherapy, which includes capecitabine and temozolomide. And in today's talk, we'll go over the data that informs us how to sequence all of these treatment options or perhaps combine them in the treatment journey for neuroendocrine tumors. We'll start by talking about the evolving role of lutetium dotatate PRRT. So as you know, lutetium dotatate or Lutathera PRRT is the cornerstone of systemic therapy for neuroendocrine tumors. Shown here are the results of the NETR1 study, which is the study that got Lutathera approved in our country. This study took patients with well-differentiated advanced midgut neuroendocrine tumors that progress on previous somatostatin analog therapy randomized them to getting Lutathera compared to high-dose octreotide. And it's shown that lutetium dotatate led to a significantly improved progression-free survival of 28.4 months compared to 8.5 months in the control group. The hazard ratio was 0.21, so 79% reduction in the risk of progression or death with lutetium dotatate. The response rate was also better, 18% with lutetium dotatate compared to 3% with the control group. And there was also a trend toward improved overall survival, 48 months compared to 36 months in the control group. And so as a result of this data, lutetium dotatate is approved for second-line treatment for patients with advanced neuroendocrine tumors of GI origin. And now we're going to look at data that supports the use of lutetium dotatate in the first-line setting. So we'll be talking about data from the phase 3 NETR2 study. This is a study that enrolled 226 patients with advanced well-differentiated neuroendocrine tumor. The tumors were grade 2 or grade 3 with the Ki-67 of 10 to 55%. And these patients were treatment naive, have never received any systemic therapy. The patients were randomized in a 2-to-1 fashion to getting lutetium dotatate compared to the control arm of high-dose octreotide LAR. And at the time of disease progression, they were allowed to cross over. I wanted to show you the patient demographics. So in this study, about 2/3 of the patients had grade 2 disease, whereas 1/3 of the patient had grade 3 disease. The Ki-67 range was 10 to 50% with the median of 17%. So here are the results of the NETR2 study. So lutetium dotatate in the first-line setting in the grade 2 and grade 3 NET population showed a progression-free survival of 22.8 months compared to 8.5 months in the control group. The hazard ratio was 0.28, meaning that lutetium dotatate in the first-line setting led to a 72% reduction in the risk of progression or death compared to the control group. The response rate was also significantly higher, 43% with lutetium dotatate versus 9% with the control group. And it's also been shown that there's no new safety signals with lutetium dotatate used in the first-line setting in this population, and that the quality of life was similar in both arms. And so my take-home points are that lutetium dotatate significantly improves progression-free survival for patients with well-differentiated grade 2 and grade 3 neuroendocrine tumor with a Ki-67 of 10 to 55% in the first-line setting. But does this mean that we should use PRRT first-line for everyone? Well, not necessarily, because there's no overall survival data yet to suggest that this will overall help people live longer. There's also many long-term toxicities of PRRT to consider, including myelodysplastic syndrome and others. And there's also many other great treatment options for neuroendocrine tumors, including surgical debulking and liver-directed therapies and other novel systemic therapies. So in other words, this is a marathon and not a sprint. And just because you start out running faster in a marathon doesn't mean you're going to come out ahead. So now we'll go over some data that informs our sequencing of lutetium dotatate in the treatment journey. So this is our own data from the University of Chicago. So it's a retrospective analysis of patients who received PRRT and CAPE-10 and seeing which one is better. So we took 59 patients in our analysis, and we look at the progression-free survival of patients who got PRRT versus CAPE-10. So the median progression-free survival was 21.9 months for PRRT and 20 months for CAPE-10, but it was not statistically significantly different. So overall, there's no significant difference in progression-free survival, response rate, or overall survival in our analysis. However, if we look at subgroup analysis, it seems that the progression-free survival was improved with CAPE-10 in patients with grade 3 disease. So with CAPE-10, it was 16 months compared to 8 months for PRRT. And the PFS was improved with PRRT in tumors that have mutations in MEN1, DAX, and ATRX. So in this instance, the PFS was 28 months with PRRT compared to 19 months with CAPE-10. And so perhaps for patients with grade 3 disease, we want to start out with CAPE-10. And for patients whose tumors have mutations in MEN1, DAX, and ATRX, we may want to use PRRT first. We also showed that CAPE-10 produced a faster time to response than PRRT. So the time to response was 6 months with CAPE-10 compared to 11 months with PRRT. Therefore, for patients with large tumor burden, very bulky disease, or very symptomatic disease, or rapidly progressing disease, or patients who we're trying to induce rapid tumor shrinkage to get them to become a surgical candidate. These may be patients who are ideal for starting off with CAPE-10 as opposed to PRRT. And of course, this was a retrospective study, which is fraught with all the limitations of a retrospective study. And so we need prospective clinical trials to help us answer the question, which one is better to start off with. So this is a phase 2 compare-NET study that's currently enrolling for advanced well-differentiated pancreatic neuroendocrine tumors, starting with lutetium dotatate compared to capecitabine and temozolomide. Here are some of the other studies that are trying to answer the treatment sequencing question for PRRT. So this includes the phase 3 COMPETE study of lutetium edotriotide PRRT versus everolimus in grade 1 and grade 2 GEP-NETs, and the phase 3 COMPOSE study of lutetium edotriotide PRRT versus the physician choice of best standard of care for grade 2 and grade 3 GEP-NETs, and in this instance, the best standard of care includes everolimus, CAPE-10, or FOLFOX chemotherapy. So now we move on to some of the data looking at combination approaches with lutetium dotatate. So PRRT and CAPE-10 are both very effective treatments for neuroendocrine tumors. So what does this data look like if we combine them? We're going to look at the data from the phase 2 control NET study. So this is one of the cohorts of the study that enrolled patients with advanced grade 1 and grade 2 mid-gut neuroendocrine tumors, randomized them in a 2-to-1 fashion to getting PRRT plus CAPE-10 combination therapy versus the control arm of PRRT alone. So there were 32 patients in the combination group, 13 patients in the PRRT control group. So I've shown the data here in the table. As you can see, in the combination group, the response rate was 34% compared to 23% in the PRRT alone group. But the progression-free survival rate at 36 months was very similar. It was not significantly different. It was 60 and 61%. However, the combination group had a significantly higher rate of grade 3 and grade 4 toxicity. So the rate was 88% in the combination group compared to 46% in the PRRT group. In terms of long-term hematologic adverse events, it was 13% with the combination group and 31% with the monotherapy group. So my take home, at least for the data for this cohort for mid-gut neuroendocrine tumors, is that the combination therapy maybe led to a slight improvement in response rate, but really no difference in progression-free survival, but the combination therapy was significantly more toxic. The same study also had a different cohort with pancreatic neuroendocrine tumor, grade 1 and grade 2. These patients are randomized in a 2-to-1 fashion to getting combination of PRRT and CAPE-10 versus the control arm of CAPE-10 alone. So 18 patients were enrolled in the combination group and 9 patients in the CAPE-10 alone group. So shown here in the table are the data. So the combination group led to a response rate of 72% compared to 33% with capecitabine and temozolomide alone. And the 27-month progression-free survival rate was also significantly higher, was 61% with combination therapy compared to 33% with CAPE-10. In terms of long-term hematologic adverse events, it was 17% with the combination group and 0% with CAPE-10 alone. So in the pancreatic neuroendocrine tumor cohort, at least for this study, it seems that the combination therapy definitely led to improved clinical outcomes, although also more toxicity, and may warrant further study in follow-up larger phase 3 trials. Here are some of the ongoing PRRT combination trials. So this includes combination of PRRT with triampine, which is a ribonucleotide reductase inhibitor, combining PRRT with olaparib, which is a PARP inhibitor, and then combining PRRT with M3814, which is a DNA PK inhibitor. So now we're going to switch gears to talk about alpha particle PRRT. So what is alpha particle PRRT? Well, this is PRRT that uses alpha particles such as actinium and lead, as opposed to traditional PRRT that we have available using lutetium, which is a beta particle. So alpha particles have a shorter range and therefore allows for more selective targeting of the tumor cells while sparing the healthy surrounding tissue. There's also higher linear energy transfer compared to beta emitters, leading to complex DNA double-stranded breaks. So scientifically and theoretically, alpha PRRT would be better than beta PRRT. However, what does the clinical data show and how does this inform our treatment sequencing? So recently presented at our ASCO annual meeting is the data from the phase 1 and phase 2 Alpha Medics 01 and 02 trials, looking at alpha PRT with lead dotamtate in patients with PRT naive GEP-NETs. So the combined analysis included 44 patients who got lead dotamtate. The response rate was 56.8%. The 24-month progression-free survival rate was 74.3%, and then the 24-month survival rate was 90.7%. Shown in the picture on the bottom left are 2 patients who responded very well to this alpha PRT therapy. In terms of toxicity profile, there was no substantial hematologic toxicity. They did see grade 3 or grade 4 lymphopenia, but that was mostly reversible. They also saw mild to moderate alopecia, which is transient, and then they saw dysphagia, which is difficulty in swallowing from achalasia. So it seems like somehow this treatment is affecting the motility of the esophagus. So these are definitely encouraging initial clinical trial results. I'm definitely eagerly awaiting the results from the other cohort of patients in these trials who have been previously treated with beta particle PRT to see what is the activity of alpha PRT post-progression on conventional PRT. And in the future, we probably will see randomized trials to help us answer the question whether we should start with alpha PRT instead of conventional PRT, or whether we should save alpha PRT upon progression on conventional PRT. So now we're going to move on to talk about targeted therapies with a focus on cabozantinib. So just as a reminder, this is the current treatment landscape for targeted therapies in well-differentiated neuroendocrine tumors. So for pancreatic neuroendocrine tumors, we have everolimus and sunitinib as the FDA-approved options. And for other GI and lung neuroendocrine tumors, we have everolimus. Cabozantinib is a targeted therapy drug that targets VEGF, MET, AXL, among many other pathways. So these are pathways that affect the tumor cell's motility and invasion, affects how they make new blood vessels, and affects how the tumor cells hide from the immune system. So recently there was positive data presented from the phase 3 CABINET trial for cabozantinib in neuroendocrine tumors. So this study took 290 patients with advanced, well and moderately differentiated neuroendocrine tumors, randomized them in a 2-to-1 fashion to getting cabozantinib compared to placebo, with crossover allowed at disease progression. So let's first look at the cohort of patients with extrapancreatic neuroendocrine tumors. So there were 197 patients in this cohort. I want to point out that the median time from diagnosis to enrollment in the trial was 87 months. So in other words, 7 years into the patient's treatment journey. The median numbers of prior lines of systemic therapy was 2, but ranged from 1 to 7. So in other words, this was a heavily pretreated population. This study also included patients with well-differentiated grade 3 disease, so about 6 to 9% of patients. So here are the results for the extrapancreatic neuroendocrine tumor cohort. So the median progression-free survival was 8.3 months with cabozantinib compared to 3.2 months with the placebo group. The response rate was low, was 4% for cabozantinib and 1% with placebo, and the survival was not significantly different. And now we'll look at the cohort of patients with pancreatic neuroendocrine tumors. There were 93 patients in this cohort. So again, this was a heavily pretreated population. The median time from diagnosis to enrollment was 84 months, so 7 years into the treatment journey. And the median number of lines of prior systemic therapy was 3, with a range from 1 to 9 in the cabozantinib group. This cohort also included patients with well-differentiated grade 3 disease, so 10% of patients had well-differentiated grade 3 disease. So here are the results for the pancreatic neuroendocrine tumor cohort. So cabozantinib led to a median progression-free survival of 11.4 months compared to 3 months in the placebo group, with a hazard ratio of 0.67, meaning a 33% reduction in the risk of progression of death. The response rate was significantly higher with cabozantinib, 18% compared to 6% in the placebo group. And the survival was also numerically higher, so 43 months compared to 31 months with placebo. So here are my summaries for the CABINET study. So cabozantinib significantly improves progression-free survival in well to moderately differentiated neuroendocrine tumors It's active even in patients who have received many previous lines of systemic therapy. And the adverse events are consistent with the known safety profile of cabozantinib. So what does this mean for treatment sequencing in our practice? Because this drug has activity in heavily pretreated patients, we generally reserve it for later on in the treatment journey, usually after the patients have received PRRT. So some unanswered question from the data I've shown you is the treatment effect of cabozantinib by primary site of tumor, by grade, by number of prior treatments, and ultimately we need better predictive biomarkers. So what about combining cabozantinib with immunotherapy with atezolizumab? So I'll show you here some of the data. So as we know, immunotherapy by itself with checkpoint inhibitors doesn't really work well in GI or pancreatic neuroendocrine tumors. There's also scientific and biologic synergy between checkpoint inhibitor immunotherapy and cabozantinib, and therefore this was the rationale for this phase 2 CABA-10 study. This was a basket trial, and we'll look at the data for the grade 1 and grade 2 GI pancreatic neuroendocrine tumor cohort, of which there are 24 patients, and also the cohort with grade 3 extrapulmonary neuroendocrine neoplasms, of which there was 9 patients. So the grade 1, grade 2 GEP-NET cohort, the response rate of cabo plus atezo was 16.7%, with a progression-free survival of 13 months. For the grade 3 extrapulmonary neuroendocrine neoplasm cohort, unfortunately, none of the patients responded to the combination, and the progression-free survival was only 2.7 months. So my take-home is that, unfortunately, adding atezolizumab immunotherapy to cabozantinib doesn't really lead to enhanced efficacy, so not better than doing cabozantinib by itself. So to conclude, I want to remind everyone that the treatment journey for neuroendocrine tumors is a marathon rather than a sprint. In a marathon, we can start out by running fast, but it doesn't mean we'll necessarily come out ahead. So this is where we really need clinical trials to help us answer these important questions, and I highly encourage everyone to participate in clinical trials. And as I've shown you in today's talk, there are many ongoing prospective clinical trials to help us clarify what's the optimal systemic therapy sequencing or combination approach for neuroendocrine tumors. We also need studies to help us develop better predictive biomarkers to guide treatment based on who's going to respond to which treatment. And finally, because the treatment landscape is so complicated, we really need a multidisciplinary team to develop the best individualized treatment approach for each patient. Thank you very much.
Hi, everybody. My name is Osman Ahmed. I am an interventional radiologist at the University of Chicago. And today I have the pleasure of speaking with you all about liver-directed therapies, which is essentially what I do, and as well as histotripsy. So interventional radiology or interventional oncology, they're sort of used interchangeably, are treatments that we perform in the liver. And we often do this for neuroendocrine cancer patients. So one of the questions I get frequently asked is, why is the liver a common organ that is treated by interventional radiologists? And the reason is that the liver is very unique for a few reasons. One, it is incredibly resilient. So it has the ability to repair and regenerate itself, especially if it receives insults. So even, things like alcohol or trauma, the liver can repair and regenerate itself. But even, with the treatments that we perform, where we can actually attack the liver, the normal liver has the ability to sort of repair itself. In addition, the liver is also very unique because it gets blood flow from two different sources. One is the artery, just like most other organs get blood flow from the artery, but it also gets blood flow from a large vein known as the portal vein. And that will be important for a few different reasons. But first, let's start with what are the treatments that we can perform in interventional radiology for our neuroendocrine cancer patients. There's really two main types of treatments for the liver that we perform from an interventional approach. One type of therapy are known as transarterial therapies, where we actually go through the arteries and using X-ray guidance can deliver materials to tumors. And then the other is a more direct approach, and this is known as percutaneous ablation, where we're actually directly placing a needle inside of a tumor. And we'll talk about both of these. But let's first start with transarterial interventions where we're going through the arteries. And so transarterial interventions, what we're trying to do is we're actually trying to just shut the blood flow down to the tumor. And that term or concept is known as embolization. Just now, we talked about how the liver is very unique in that it has two sources of blood flow. One is the portal vein, and then in the normal liver, about 3/4 of the blood flow is from the portal vein, and about 1/4 of the normal blood flow in the liver is from the hepatic artery. What's very unique about tumors in the liver, and specifically neuroendocrine cancer tumors, is that the blood supply is primarily from the hepatic artery, about the reverse. So about 75 or 80% of the blood flow is actually from the artery itself. And so therefore, if you can do embolization or shut down the artery flow to the tumor, you can preferentially kill the tumor without really damaging the normal liver. And so this is kind of a cartoon schematic of what's kind of happening is we can take a very small tube or catheter all the way up to the tumor, and we can inject a variety of things. And depending on what we inject is the name of the type of embolization. So if we inject just regular beads or particles, that's known as bland embolization. And we can use really, really small particles, as small as 40 microns. And just for reference, the capillary is about 5 to 10. So it can get very down to the tiniest arteries to the tumor. However, if we inject chemotherapy, that's known as chemoembolization. And you can inject a variety of chemotherapeutic agents like doxorubicin, cisplatin, mitomycin, irinotecan. And then we can also inject radioactive microspheres, and that's known as Y90 or radioembolization. But these are all based on the same principle, which is to take a very small catheter all the way up to the tumor. So this is how this sort of works in real life. So this is, again, a cartoon schematic showing how most of this tumor is actually getting blood flow from the red vessel, which is the artery. And this is what it looks like on a CT scan. You can see here there's one nice big artery going to that sort of Death Star looking tumor. And this is what it looks like on an angiogram. So that was what it looks like in a CT. But when I do this procedure, this is what an angiogram looks like. So where we take the catheter, we get it all the way up into the artery, and you can see that there's clearly one artery kind of going and feeding this tumor. So we get a very small catheter all the way up into that artery. And once we're up there, then we can do whatever we want to do. So if we want to inject those particles and do bland embolization, we can do that. If we want to inject radiation, we can do Y90 or radioembolization, we can do that as well. But the technique is the exact same. So oftentimes what we're asked is like, well, a lot of what you do, that seems to compete with surgery, because should I have a surgery or should I have one of these therapies? The reality is that we actually work very well or complementary with surgery. Specifically, we kind of work hand in hand, especially at our tumor boards, to sort of decide what is the best option. And so oftentimes, if surgery is more appropriate, we go with surgery, but it's not uncommon where surgery is not an option. So one example would be there's too many tumors in the liver to go in and remove. Whereas to do a transarterial therapy, for example, where you could blanket all those tumors, that then would make more sense. We also oftentimes sort of work hand in hand with surgery as a combination strategy. So I'm going to show you a few examples of where surgery is very effective in clearing about 90 or 95% of the tumor, but then, we kind of come in on the back end to kind of clean up the rest or clear the rest. So here's a first example. This is a 60-year-old male who had a small bowel neuroendocrine cancer metastatic to the liver. And so the first step in approach to this treatment was to do a small bowel resection, to do a liver wedge resection, so try to get out as sort of the bulk of the tumor, and also take out the gallbladder, cholecystectomy. However, the patient underwent after surgery a follow-up MRI. And on this follow-up MRI, you can see there's some residual tumors left in the left lobe of the liver. So there's one there. Here's another slice. You can see there's actually 2 tumors here. So just to review, this patient has multiple small residual tumors in the left lobe. As you can see, there's probably maybe 4 or 5 tumors there. From an interventional perspective, since there's many lesions, more than 3 as I like to define that, we're going to try to target these tumors from an intra-arterial approach, because it would take a lot of time, effort to put 5 needles into those tumors. With this approach, where we actually go into the hepatic artery, into the liver, we can sort of from the inside treat all of those tumors at one time. And the goal would be to basically try to starve the tumor of its blood supply and kill or shrink the tumor. And so that procedure, as we just talked about, is known as bland embolization. So we're going to inject these plain or bland beads. And what we're going to try to do is cause an ischemic effect. Ischemic means to basically starve it of its blood supply. And so when you do that, the tumor, again, gets most of its blood flow from the hepatic artery, will basically necrose or die, and will be able to either shrink or kill these tumors. And as we talked about, we can inject beads that are as small as 40 microns, so very, very, very small beads to get really, really deep into the tumor and really kind of get a good tumor kill. So this is another picture of an angiogram, and this is the angiogram for this patient. You can see these are the hepatic arteries. So the catheter is actually in the artery that feeds the whole liver. And what I'm pointing out here with the circles are actually those tumors that we saw in the MRI. So this is what that looks actually like, an angiogram. So now what we need to do is actually go, so this is into the whole liver. We need to go into just the left side of the liver. So these are those left lobe tumors that we saw in the MRI. So what we're going to do is we're actually going to go into the left lobe of the liver. And you can see here we have a very tiny catheter here that's into that left lobe or the left hepatic artery. And from this position, we can proceed with our bland embolization, where we're going to inject these beads and really try to shut the blood flow down. And you can see here, here's a repeat angiogram, and there's no more flow to that left hepatic artery. So this is what we're going to do, is try to shut that blood flow down. And you can see here on the follow-up MRI, before these tumors were lighting up like light bulbs because they got their blood flow from the hepatic artery, and now the light bulb has burned out. So there's no blood flow there. So that's a dead tumor right there. And then what was interesting on this patient was where all those other little tumors were, we actually didn't see those tumors at all because they were so small that once we killed them, they basically disappeared. So they completely were obliterated. So we're really, really happy with this effect. And so working with surgery, we were able to sort of clear this patient's liver of tumor. So here's another example. This is a patient who had a pancreatic neuroendocrine cancer. And he underwent a pancreatectomy and a splenectomy. So they removed the pancreas and the spleen, and then also underwent partial liver resection as well as some intraoperative ablation of tumors. So they did a really, really extensive, excellent surgery. However, on the follow-up scan, there was just one single little tumor left in the liver. So the patient was referred to us to manage that single little tumor. So you can see here on this, there's one little tumor that's lighting up like a light bulb. And all these other little black spots, these are the tumors that were already killed at the time of surgery. So we just have one little tumor left, and these are the dead tumors from surgery. And so it would be kind of overkill to bring this patient back to the operating room and kind of go after that little thing. So we complement surgery very well here, I think, by doing a touch-up and just getting that last little tumor. And again, since it's only one tumor, unlike the other patient who had multiple lesions, we're going to do a more targeted treatment where we're actually just going to take a needle and put it into that tumor and kill it that way. And that procedure is known as percutaneous ablation, where we put that needle in there, and depending on what we do, so the most common type of ablation is known as thermal ablation, and we divide thermal into heat, so we can either do RFA, radiofrequency, or microwave. More often than not, we do microwave. If we want to freeze a tumor, that's known as cryoablation. And then if we want to electrocute the tumor, that's known as IRE. So what we decide really depends on a couple different factors that's not really important to talk about today, but knowing that we have a bunch of tools available to us to do that. So you can see here on this patient, this is the CT scan. So just like on that MRI, you can see the little tiny tumor there lighting up like a light bulb. And so what we're going to do is we're going to just go ahead, and I wish it was this easy, but you can see the needle has now been placed into the target. So the needle is perfectly within that tumor right now. And we're going to connect it to the machine, and we're going to go ahead and burn this one away. So this is called microwave ablation. And so before you saw that tumor looked like a light bulb, and now you can see here after just 5 minutes of burning it, we've created a nice big cavity of dead tumor. So this patient did very well, and then 2 years later came back, unfortunately, had an MRI that showed another new single liver lesion. And again, you can see here, kind of close to the old one, but in a different spot. A new tumor that's a little bit bigger, but it's still small. So 3 centimeters is kind of our cutoff. And so the same thing, kind of thoughts through our head was, again, we only have a single lesion here. It's very small. It's 3 centimeters. And again, it would be probably overkill to go back to the OR to treat that surgically. So we're going to go ahead and proceed with another percutaneous ablation. So this is just a rinse and repeat type of situation. You can see here, there's a tumor on the CT. Here's the needle in the target. So it's very similar. Get the needle in there. And then you can see here, this is after a 6 or 7 minute ablation. You can see here, it's no longer lighting up. It's just a dead cavity right there. And then this is on the follow-up. You can see here, this is a very tricky spot. It's in between some blood vessels, but we're still able to thread the ablation needle in there and burn that tumor away. So we're going to finish just talking about histotripsy a little bit because there's been a lot of excitement and questions, enthusiasm about it. So histotripsy is a non-invasive and a non-thermal method of ablation. So it doesn't need heat or cooling to kill the tumor. And the way it's non-invasive is that it actually uses ultrasound to create cavitation to a focal area. It is FDA approved for liver ablation, and we are actually one of the few centers in the country right now that has the commercially available unit, which is known as the Edison device. This is what histotripsy is actually doing. It's basically creating a cavity non-invasively. It's creating like as if an asteroid hit this liver and basically obliterating that area, kind of creating a liquefied homogenate there. This is what it looks like. This is one of the first procedures we ever did. This is the histotripsy actually in action. You can see here on the left, we're using ultrasound to identify the tumor, and then it's basically shooting the focused or targeted ultrasound to that red sort of bullseye area there. And this is what it looked like after the treatment. You can see here, just again, the light bulb has been burnt out, so we just see a black cavity there. And what's very interesting is this patient had a blood vessel almost running through the tumor, and histotripsy selectively only kills tumor. It's very protective to blood vessels, bile ducts, and that's another reason there's a lot of excitement around it. And you can see here, there's actually just a blood vessel running right through it, and it wasn't really impacted at all by the histotripsy. So the appeal for histotripsy is that it's completely non-invasive. It's robotic, so it's very precise. We basically draw a circle of where we want the histotripsy to kill or target, and the robot will essentially do it in an automated fashion. It's non-thermal, so we don't have to worry about burning or freezing critical structures that might be close by, like blood vessels and bile ducts. And it's also a single session therapy. In addition, there's no radiation, like we just talked about. This is all ultrasound based. You can treat multiple tumors at one time. Again, just like ablation, we like to treat up to probably 3 tumors. And it's also a platform technology. It's not just meant for the liver. It can actually treat other organs like the kidney, which there is a actual study, a human study underway, pancreas as well, prostate, and soft tissue. These have already been described in either animal studies or human studies. This is the actual Edison device with a cheesy picture of me standing in front of our unit. And this is from a procedure we actually just did very recently. This is the sort of the new clinical version, the one that's FDA approved. Looks a lot more sleeker than the original one that I showed you. And you can see here, it's all very nice touchscreen, kind of like an Apple iPad, and then the robot there over the patient. This is what it's actually doing. So the ultrasound is basically held outside of the patient or just robotically placed right above the patient. Once you target the tumor, you can actually see it focuses ultrasound and creates this bubble cloud that basically creates cavitation within the targeted area and mechanically destroys and liquefies the tissue. With that said, there's still much to do. Histotripsy is not, fully ready for prime time where we can treat every single patient. Since it utilizes ultrasound to target tumors, you have to be able to see the tumor under ultrasound through the water bath that you can see here on the left side. So it is limited to tumors that we can mainly see under the rib cage because the ribs block the ultrasound. So not everybody is eligible, and only a small percentage of patients right now are eligible. In addition, it's a new technology with limited data, so we're still learning where it's best utilized for. With that said, it's very exciting, and I think there's a lot of opportunity to develop the technology further. So I'll conclude by saying interventional radiology utilizes imaging techniques to help kill tumors in a very minimally invasive way. Everything that we do, pretty much we just put a Band-Aid on at the end, and patients either go home the same day or the next day. And as we talked about, you can treat tumors of the liver through the arteries, which is known as embolization, or directly putting a needle into the tumor, and that's known as ablation. This works very well with surgery to help clean up things if there's any tumors left behind, or for patients who might not be eligible for surgery. And then, as we just talked about, histotripsy has a lot of promise as a new non-invasive method of ablation. So we're going from minimally invasive now to hopefully even completely non-invasive for some of our patients. So I'll finish here. Always happy to answer any questions. You can reach me through social media, or you can always ping me via email as well. Thank you so much.
Okay, welcome everybody to our 2024 virtual education conference from the Neuroendocrine Tumor Research Foundation. We're really excited to have you here today for our virtual tumor board. We have a great team. We have Dr. Heloisa Soares from the University of Utah, Dr. Aman Chauhan from the University of Miami, Dr. Mark Lewis from Intermountain in Salt Lake City as well, and then Dr. Ahmed and Dr. Liao, as well as myself from the University of Chicago. Again, thank you for being here today. So let's dive right into it. This first case is a 50-year-old female with diarrhea that presents with diarrhea, flushing, and abdominal cramps. She goes to the emergency room. She also reports some weight loss. A CT abdomen pelvis shows numerous hepatic lesions. as well as a 2-centimeter ileocolic lymph node. And she gets worked up for this. She gets a colonoscopy and a liver biopsy that eventually show a well-differentiated small bowel neuroendocrine tumor with a Ki-67 of 10%. A serotonin level is quite high at 1330. That's much higher than normal. As we all know, usually serotonin levels are below 200 or 250, depending on the laboratory. And so as a workup, she gets a CT scan. This is the one from the emergency room that, as you can see, shows numerous lesions in the liver here, but then the blue arrow points towards the primary tumor within the small bowel here, the distal part of the small bowel. She gets a dodate PET scan, which shows numerous lesions within the liver, as well as the primary tumor and the ileocolic lymph nodes that were seen on the CT scan in the emergency room. And then she also gets an MRI with EOVIST, which shows, like the radiologist would call it, innumerable bilobar hepatic lesions. Certainly you can count them, but there are quite a bit here. So she is being started on long-acting octreotide as first line, as we all know, both for symptom improvement as well as for tumor improvement. And she reports some mild improvements in her diarrhea and flushing. So before we move on to the next part of what we did, I would ask perhaps Dr. Soares whether there's anything else that she would want to do at this sort of early stage. And you will see this is a multi-year story. So obviously this is the very beginning. After the diagnosis, a lot of things are going to happen. But is there something in particular at this point? You have a patient that has some mild improvement in her diarrhea and flushing, still reports some cramping. You've seen the images. Is there something else that you would recommend that we do at this time, or would you just continue to follow her?
Thank you so much. Unfortunately, this is a presentation that we see not so infrequently as the first presentation. I think obviously there is the concern that all this is related to carcinoid syndrome. So in addition to the serotonin, I'll probably get to complement that a 5-HIA, potentially pro-BNP and an echo, depending on the results, to rule out carcinoid heart disease as part of the screening. That's in terms of thinking about some of the issues with her carcinoid syndrome. Then, because of her tumor intact in the small bowel and the history of cramping, there certainly, I think, deserves a conversation about resection of the primary tumor, because that can improve her symptoms. Whether or not, consideration for liver debulking can be considered, I think it really depends on the institution that the patient is being seen. Some institutions are more aggressive than others. There's data that suggests that debulking up to 70%, if is achievable, can also improve survival, at least in retrospective analysis. So all these are considerations for this patient. Consider resection of the priming, whether or not there's a role for liver debulking. And again, that's a larger conversation. And we shouldn't forget about screening for carcinoid heart disease. These are initial thoughts. I'm sure there's more from my colleagues.
Dr. Sean, anything you want to add to this?
Yeah, with such high serotonin, I think I always worry about getting a baseline screening for carcinoid heart. So Dr. Soares covered those bases. The other thing that we can potentially add on here is maybe Zermelo. This patient is still having carcinoid syndrome diarrhea, which is technically refractory to SSA alone at this point in time. It's not fully resolved. So that's the classic FDA-approved indication for Zermelo or telitrestat ethyl. Now, this drug, it targets the production of serotonin in the neuroendocrine tumor cell, unlike SSA, which blocks the secretion of serotonin. So it really complements. And if diarrhea is still a quality of life limiting issue for this particular patient, we can certainly add Zermelo, and that have shown to improve carcinoid syndrome diarrhea. But beyond that, for medical management for metastatic disease, I think the case needs to be reviewed in a multidisciplinary setting to really chart what's the next best treatment. I think Dr. Soares brings out a good point about debulking for functional nets that could be hugely beneficial. But in this particular case, some might say there's too much of disease. Unless there's a concern for bowel obstruction, maybe surgical debulking can be, we can trend the tumor biology, tumor growth rate. This is a grade 2 tumor, and those Ki-67 10% can be very tricky. That's really the borderline where they can be either aggressive or very indolent. So understanding the biology of the cancer, is a fast-growing grade 2 or slow-growing grade 2? It's very important. There are other therapies like liver-directed therapies that can be used. Those are relatively less invasive as compared to a debulking surgery for immediate relief or some sort of cytoreduction if it's needed for functional neuroendocrine tumor management. So again, we have multiple tools, and I think we have to factor in patients' risk for individual procedures, their choices, and their goals, and also factor in the multidisciplinary tumor board recommendations and what expertise are available. For example, you guys at University of Chicago, you're very well known for NET surgeries. Not every center might have very expert NET debulking surgeons. So we got to factor those things in.
Thank you very much. So to both yours and Dr. Soares' point, we obviously got an echo that was all negative. She also had no symptoms. I would also add that occasionally, patients certainly with carcinoid heart disease don't have any symptoms. So no shortness of breath, no swelling over legs. And still, I don't know what your thoughts is, but generally we tend to, once the serotonin level are above 1,000, even if there are no symptoms, we tend to definitely check for that, especially if we plan on doing something a little bit more on the invasive side. This case was presented in the Neuroendocrine Tumor Board, and believe it or not, we judge this, for at least from a liver perspective, to be too high tumor burden for debulking. Like Dr. Soares said, there's different thresholds. We generally try to aim for greater than 90% because those are the better results that we've seen, especially in very symptomatic patients like she is. But, we just thought there was too much. However, one of the things that I think you both mentioned as well is to really pay attention to the patients, right? So in this particular case, her crampy abdominal pain didn't really resolve. And if you remember from the CT I showed you, that lesion was almost completely obstructive in the small bowel lumen. And so we did decide to take her to the operating room to remove the primary tumor. We thought that this was necessary to relieve her symptoms that she had, not so much the flushing and the diarrhea, but rather the crampy abdominal pain and the weight loss that she had. And so we did a laparoscopic right hemicolectomy. We took her gallbladder out, which we often do in patients with metastatic disease that actually are projected to be on long-acting octreotide for a while. And then we did a liver wedge resection just to be sure that we're dealing with the same Ki-67 or tumor grade, like you said, Dr. Chauhan, which is really important to understand sometimes for tumor biology in the primary tumor as we see in the liver. And so it turned out that the operation went very well. She recovered quickly. This was a small bowel neuroendocrine tumor, well differentiated, grade 2, 3 out of 27 positive lymph nodes, and a Ki-67 of 6% actually. Now, we, for some reason, run OncoPlus, which is molecular testing platform on all our neuroendocrine tumors, including the small bowel neuroendocrine tumors, which generally is not that helpful for small bowel neuroendocrine tumors. But these were the results. She was found to have 2 pathogenetic findings, one a mutation in B-core, which is really, I think, a loss of function mostly, and then an equivocal Notch1 loss. Anything any of the medical oncologists wants to add here that makes you nervous, unnervous? I know B-cores can be found in small bowel neuroendocrine tumors, but I don't think it has any particular prognostic value. Anything you want to add before I move on?
Yeah, I don't know we know enough about prognostic or predictive value of these two.
I would agree. I think Notch1, we are increasingly learning Notch pathway signaling in general, broadly with neuroendocrine cancers, definitely well established with higher grade, poorly different neuroendocrine carcinomas. But again, this is one of those biomarkers, we don't understand what they mean, and they're not very commonly found either. So I think it's too difficult to make sense of these things at this stage of time.
I might just add, maybe the one time I do find genomics fairly helpful in these settings is, as we all know, there are occasionally times, at least before patients go to the operating room, where you might actually not be able to distinguish readily a pancreatic from a mid-gut primary. I certainly see that from time to time. And there I find loss of heterozygosity in chromosome 18 to be a hallmark of the midgut origin. So that's sometimes helpful. But yeah, I agree. I wouldn't see anything actionable here.
Okay, so she's continued to have symptoms despite being on long-acting octreotide, on this case lanreotide, 120 milligrams every 28 days. So what now? Anybody wants to chime in and think about, anything else we could do for this patient that still is symptomatic? Obviously, her cramps go away. That's not an issue anymore, but she still has the flushing and the diarrhea.
I think like Dr. Chauhan said, telotrestat or Zermelo is an option, but controlling the symptoms also goes hand in hand with controlling the disease. So, if the tumor is not debulkable by surgery, then perhaps we could consider liver-directed therapy, otherwise a different type of systemic therapy.
Great. So Dr. Ahmed, can you talk to us a little bit about liver-directed therapy in neuroendocrine tumors, specifically in those cases where liver debulking is not a good option, either because the patient, couldn't get through it or because the tumor volume is too high?
Quick comment before we go. So it might not be fully serving this particular case, but after the debulking or primary tumor resection, for the audience, it's important to know the diarrhea and neuroendocrine tumor can be multifactorial. And especially after the surgery, short-gut diarrhea can be particularly playing a role now in addition to carcinoid syndrome diarrhea. So it'll be interesting to see how the serotonin levels or 5-HIA levels trended pre and post-operatively, so that we can really fine-tune. If it is purely a carcinoid syndrome diarrhea issue, then again, I think we will hear more about what we did to debulk further disease. But if there are additional components, some patients might get gallbladder removed, who might have some bile acid diarrhea component, bacterial overgrowth, short gut syndrome. So it's really important to understand what could be contributing to worsening GI issues.
Yeah, it's a very good point, especially as we remove the right colon, the terminal ileum and the gallbladder, you could have bile reabsorption issues, which hopefully most surgeons will know about. And so if the diarrhea gets worse, you would definitely expect that there's a component there. In her case, her diarrhea pretty much remained the same, and the serotonin level, I'll show you in a little bit, was also about the same. So we assumed that this was serotonin-induced diarrhea still at this point. Back to our IR colleagues.
Yeah, sounds good. This is honestly, where I think there's a nice role for what Dr. Chauhan talked about in terms of local regional therapy. So from an interventional radiology perspective, we have a role when patients have disease, especially localized to one organ, particularly the liver. And we tend to sort of work well when you have a lot of tumor in the liver or very little, like 1 or 2 lesions. And so in this case, as Dr. Keutgen mentioned, there was a lot of tumor in the liver, so much that, sort of going in there surgically and removing all of it doesn't seem possible or would potentially be more risky than beneficial. So the way that we treat tumor when there's a lot of tumor in the liver is through what are known as intra-arterial therapies. And intra-arterial therapies is where we take a catheter through the groin and we thread it through the artery, very small catheter, about 1 or 2 millimeters in size. Using X-ray guidance, we can take it into the liver, and then we can inject material through that catheter. And depending on what we inject is what the procedure is known as. For patients with neuroendocrine tumors, we most often do what's known as bland embolization, where we inject basically inert beads, almost like grains of sand, essentially, to plug up the arteries and starve the tumor of its blood supply. As you can see here from the PowerPoint, because there's tumor in both the right and left lobes of the liver, we can treat the whole liver, but we typically have to split that up into 2 procedures because treating half the liver at one time is a lot to recover from. And then so patients usually need about a month or so to recover from that, and then we can treat the other side.
Great, thank you. And obviously I didn't give you a real time frame here, but this happened relatively shortly. So the first few slides here I showed you happened within 3 to 4 months. So I think one of the issues which we haven't touched based on directly, but it's not always about biology and tumor progression, but also I think about quality of life. This patient was a highly functional patient that worked full time, was a mother to 3 children, and had to go on with her life. So she really was bothered by the diarrhea, which was really keeping her from doing a lot of the things she would normally do. So she sort of, needed to move on. And that's why we don't necessarily have to be that aggressive with most patients, but quality of life, I think, is a really important part, especially with carcinoid syndrome. And so I think that it's important to consider that. So her symptoms did finally improve after bland embo. Her serotonin level went down by almost 1,000 points to 364. So that's a pretty good success. And I think it also speaks for, the knowledge and the savoir-faire of our interventional radiology colleagues. But, about 6 to 8 months later, she came back to clinic. And again, we're scanning her in the meantime, no major changes, but she reports worsening symptoms again, and her serotonin shoots back up. But the MRI read at the time, says that things look grossly stable. Is there anything you would want to do at this time point? Maybe Dr. Soares, you could comment if there's anything else that you think this patient would need.
Again, it's all about the conversation with the patient and goals of care, because there's other strategies. If you believe really the disease is stable, it's just progression of the functional status, then you can discuss, in addition to the later stat, you can discuss strategies to increase the frequency of the somatostatin analog or the dose if you are in octreotide, and if you are in lanreotide, you can do every 2 weeks. But this is a patient that actually, if we think about an error to study that was recently presented and published with a Ki-67 of 10% and quality of life being something very affected, and the high tumor burden of disease, it's not unreasonable to consider PRR3 treatments. Again, depending on the conversations with the patient, is at least worth the conversation here. And 6 months later, you can argue that would you want to try more liver embolizations? I personally prefer to see at least a good year of benefit before trying again, but it's certainly conversations that can take place.
Yeah, very good. So I think, like you suggested previously, starting her on telorastat was thought to be the next step because, again, she was very active, she was working, she didn't want anything really more at that time. And this was sort of an easy thing for us to just do. But unfortunately, she didn't have any major improvements in her symptoms.
And may I just ask, did she stay on the dolutegravir for a good 3 months?
Yeah, she did. So we'll make sure that she always tries 8 weeks at the minimum. I think it's an important point you bring up because symptoms may not improve within 2 weeks. We know that, right? So we generally tell our patients to stay on it for at least 2 months before they stop. So we got to repeat dotatate PET because, I think it's important to remember that MRIs sometimes will show obviously what happens in the liver, especially when you have a lot of liver disease, confluent liver disease like she has. It's sometimes challenging to really assess true progression. I don't know if you've found similar things, but she got a repeat dotatate PET, and the dotatate PET showed worsening of her liver disease as well as some new retrocrural lymph nodes. So sort of a very mild and small extrahepatic disease. Dr. Lewis, at this point, symptoms getting worse, clearly had some progression, some, although very small amount of extrahepatic disease. Anything you would recommend that this patient be started on at this time?
Yeah, I think I'll combine my colleagues' comments, which I thought were extremely insightful. The word aggressive has always struck me as very subjective. So sometimes patients will ask me, even at the very first visit, doctor, is this aggressive? I like the way that Dr. Shahan put it, that, honestly, disease biology will declare itself in time. And the Ki-67 of 10% is really an interesting sort of liminal number that, yes, is grade 2, but as he was saying, can kind of go either way. And so I would, again, reiterate what Dr. Soares was saying, that as of this year, as of ASCO GI, and the publication of the NETRF data, which of course places PRRT with somatostatin analogs right up front, I would strongly consider PRRT given this dotatate PET, which really by the lock and key hypothesis shows that there is still disease that's targetable, not just with analog, but with therapeutic radionuclide.
So this is exactly what we did. We started on PRRT. She had improvements in her symptoms, and her serotonin level ranged from 274 to 406 over the treatment period of 8 months. So she definitely improved dramatically and probably felt the best that she had in many years. A repeat dotatate PET-CT a year later showed stable disease. You even see maybe some of this extrahepatic disease. These retrocrural lymph nodes are not as obvious anymore on the dotatate PET. But 2 years post-PRT, her symptoms worsened again, and her serotonin crept back up again above 1,000. So what now, Dr. Liao? Any recommendations?
Yeah, I think, we would be worried about disease progression. And then the question is, is it mainly the liver or outside the liver? Because our treatment options may be different. So if it's within the liver, we may still be able to consider something liver directed, such as embolization or debulking, which is now the candidate. But if it's more systemic progression, then we will choose another systemic therapy. So I think the MRI here shows mainly liver progression, right?
That's right. Yeah. So this is a really interesting case because what ended up happening, and you have the two dotates next to each other here within a year period, is that she mostly had progression of a single lesion in segment 2 that sort of rapidly appeared out of nowhere. And she had some progression in segment 4, but not dramatic. Really, it was the segment 2 lesion here that you could see very clearly on the dotate that really significantly changed, came out of nowhere. So, Oz, from an IR perspective, anything you can offer for a lesion? This measured about 3.5 centimeters.
Yeah, definitely. So this is now we're talking about sort of the other spectrum where we often are asked to sort of evaluate patients is when you have maybe one lesion in this situation that's growing out of control, whereas the rest of the disease is stable. So when we're trying to target just one lesion, we can start thinking about some of our percutaneous treatments, which are treatments through the skin directly into the tumor. And that's specifically ablation is one good option. Ablation is where you take a needle through the skin directly into the tumor. You can either burn it or freeze it or even electrocute it. Ideally, we like to do it for lesions that are 3 centimeters or smaller because those tend to be treated best. And again, depending on the location, we can also do very focal embolization as well. So I don't recall what we did here, but this does look like it's in a favorable location for ablation.
Right. So yeah, in this particular case, I have to smile because Dr. Chauhan, before we started the Tumor Board, said, well, the case you're going to present, the answer is easy. Everybody goes through surgery. Well, this was presented at Tumor Board and we went back and forth and we thought that certainly we could destroy this, but we weren't sure whether percutaneous approach would really significantly help her symptoms. And so we also wanted a good chunk of tumor because we wanted to run some more additional tests, especially to see whether this is a tumor that is slowly de-differentiating. So we sort of bit the bullet, and I gotta tell you, this is not generally cases that I as a surgeon like to debulk because like I said, we generally aim to go over 90% debulking, which clearly, look at the dotatate PET, in this case is not possible. But we did take her to the operating room and we removed quite a bit of tumor. So you can see here multiple deposits ranging from 4 to 8 centimeters, essentially. So, looking at putting all of these tumors together was basically bigger than an orange in terms of what we were able to remove. The fascinating part was this. So we asked our pathologists to specifically look at different blocks, and the segment 2s turned out to be with a Cat67 of 20%. The segment 5, which was the other one, 4, 5 that was growing, was 12.5%, and the other ones were 1%. So this, I think, is a really interesting finding. I'm curious to see what the team is going to say about this. But before I give you the floor, I will add that again, we run an OncoPlus, and again, it showed a B-core mutation, but also now we had a SMAD4 loss and perhaps more importantly, an RB1 loss. So when you see this report here, and I know we don't always get to see reports like this after PRT, after liver-directed therapy, to have so many multiple samples, but what runs through your mind? Let's start with Dr. Soares.
Yeah, it certainly is concerning that things are picking up more speed. We tend to see this RB1 in more loss in more aggressive tumors. So that goes along with the imaging that we're seeing in the growth of some of the lesions.
Dr. Chauhan, how often do you see this heterogeneity of Ki-67s within tumors?
Actually, quite frequently, especially in the era of heightened PRRT use, and also in PNETs where people have gotten alkylator-based chemotherapy for a long period of time. I'm seeing a lot of grade migration and aggressive or upregulation of the grades. So this is not uncommon, and rarely I'm also noticing complete transformation from well-differentiated to poorly differentiated neuroendocrine carcinoma as well. this particular case, it looks like kind of genetic fingerprinting it's acquiring, like loss of RB1, which is more like pathognomic of neuroendocrine carcinoma rather than neuroendocrine tumor. These tumors are definitely evolving and getting more aggressive as we can see here. So I'm glad that you did do the biopsy or at least surgical debulking so you can understand that. So if I see rapid growth in otherwise indolent disease, I'm worried about grade migration and kind of worsening of the tumor biology. And I'll almost always do a biopsy. And I also like to do both dotatate and FDG PET in these cases, because what happens in these heterogeneous diseases, you have to really target the more aggressive biology first. So you have to understand which lesions are more hypermetabolic and which are more SSTR positive, negative, to really get a very comprehensive understanding of whether you're going to in future need chemotherapy or you'll be okay with some sort of targeted therapies.
Yeah, and postoperatively, her serotonin dropped to 4.4, her symptoms improved. So that's obviously positive for us. But to what we've discussed right now, I think that certainly this is not going to be a case that's just gonna, sit quiet for a while. It has for the last 3 months or so, but we expect that something again within the next 6 months is going to change. I guess that occasionally you could be lucky and just have wedged out just the one clone, that was the problematic one, but similar to what you said, we do think that generally this has changed overall in terms of probably multiple foci throughout this liver that now have more aggressive features. Dr. Liao, if this patient recurs relatively rapidly, and assuming there are no FDG positive lesion, but still high uptake on dotatate, would you consider retreatment with PRT? Or would you, because of the Ki-67, likely go to a chemotherapy-based approach next?
I'll consider retreating with PRT, given that it seems like she had a good progression-free interval with the first course of PRT. And we're seeing more and more data, from the NETRF for the activity of PRT for the higher grade disease. Now, had the biopsy shown something different, with the RB loss, had it shown neuroendocrine, poorly differentiated neuroendocrine carcinoma with a very high Ki-67, like 70%, I would probably move on to chemotherapy instead.
Dr. Lewis, do you think the clonal change here, so the changes of the neuroendocrine tumor cells perhaps getting a little bit more aggressive with a high Ki-67 is due to PRT?
Oh gosh, that's an excellent question. I would infer that not. I liked what Dr. Chauhan said, that in the era of more and more alkylator use, and of course we see sort of CAPTEM used more and more, especially in our PNET patients, temozolomide certainly has the sort of hypermutational profile. We sometimes do that on purpose, actually, to try to raise, say, candidacy for immunotherapy. Just based on our understanding of the rates of your therapy-related MDS with PRT alone, meaning without alkylators, I think it's less likely that temozolomide did this. I do like the points you're driving home here, though, that when the disease is not acting in a manner that is congruent with your understanding of the proliferative rate, I think we are obligated to obtain more tissue. And I think it's really important to get across this point of heterogeneity. Dr. Soares and I are involved in a very active support group here in Salt Lake. And just as most breast cancer patients would know their ER, PR, HER2 status, the leader of the support group here almost inculcates in our members and our patients that they need to know their Ki-67. I think the problem is the overly simplistic assumption that the Ki-67 is static or is homogeneous. And as Dr. Chauhan said, we sometimes see what I would say is sort of a solid tumor version of a Richter's transformation, where you go from a relatively low-grade biology to something much more threatening. And again, this is happening, as you've shown very elegantly, in the same patient at the same time. So I always focus my efforts on what I think is the most aggressive, and sometimes that means the most unexpected. Like you said, that segment 2 lesion just kind of popped up, and you showed that very nicely. And, short of a very extensive surgery like you, I think very expertly performed, I think I would have sampled the segment 2 lesion and based a lot of my treatment decisions around that.
Great. Thank you very much to all of you for participating in this neuroendocrine tumor board. I hope our patients will find this helpful. This was really, I think, a very fruitful and very insightful discussion. So thanks again for being part of this. And we will see you very shortly for the Q&A. So thank you very much.
Well, I've learned that we're a team. Yeah, I mean, yes, they are doing their thing, but they're not doing it on their own. I mean, we are in this thing together. And yes, it's a tough project. It's not always an easy one to tackle. But I feel like as a team that we could do it together.
The thing I do really love about my NEC care team is that they are very humble in what they don't know. I've spoken to many practitioners where they think they know everything, but I'm at MD Anderson, which is one of the top medical centers in the world. And I do give a lot more respect to my team when they say, I don't know. We've made phenomenal leaps in terms of efficacy in treatment, but we're basically just scratching the surface.
At the end of the day, no matter how good my doctor is, it's on me. Like I am my own advocate. I'm my own healthcare coordinator, project manager, case manager, whatever you want to say. So he's taught me that he's an input, but he's not the only input. He's also taught me to advocate for myself. So, and if I know I need something, to just be annoying, because at the end of the day, this is my life, and I need to keep pushing them. I think the other thing he's taught me, which I take very seriously, but I consider one of my jobs to make him a better oncologist. So anything I can do to introduce him to new concepts are things that I consider part of my role with him as well. So those are some of the things he's taught me.
Look at this cancer as more as a chronic disease, rather than thinking of it as cancer, which, I would agree with that. I think that definitely helps my thought and mental frame of this.
I've learned a lot from my mom's care team, but ultimately at the end of the day, I've learned that we are going to be able to get through every single day, no matter what the scans show, no matter what the reports show. We're going to get through each day because I have a supportive team on my mom's side.
Our next segment is about hope in action to live well with NETs and NECs. All you need to know about symptom management, genetics and fertility, thrivership, and quality of life. Our first two speakers are Dr. Heloisa Soares, leader of the University of Utah NET Destination Care Program at Huntsman Cancer Center. She will discuss symptom management, and then Luz Chavez, a registered dietitian and certified oncology nutrition specialist at the University of Chicago Medicine, will focus on nutrition and neuroendocrine cancer.
Hello, everyone. Thank you so much for having me here. I'm Heloisa Soares. I'm a medical oncologist who focuses in neuroendocrine cancer at the University of Utah, the Huntsman Cancer Institute. And I'm very happy to be here with you guys on my birthday to talk to you about symptom management, because it's such an important topic that I see my patients and the caregivers of my patients trying to address and make everybody feels better. So because of that, we'll touch a little bit on some education about symptom management. Thank you. These are my disclosures. And why are we talking about symptoms in patients with neuroendocrine cancers? Well, because we see a lot. This is a survey that was done by INCA that tried to understand how much we see symptoms in patients. These are all the symptoms that we can see, from fatigue to abdominal pain to flushing, diarrhea, anxiety. So you can see here that you're not alone, and there are many patients living with the same symptoms that you are. Another important thing for everybody to know is that these symptoms sometimes are very broad and generic in a way, and there are several different diseases that can cause the symptoms. And because NETs are so rare, the healthcare providers and team players might not necessarily think about the symptoms as, oh, this is the tumor, the neuroendocrine tumor that is causing that. There might be a more frequent explanation. And this often leads to delay in diagnosis of patients if this is how they initially presented, or even the management when they already have established diagnosis. that the symptoms could be generated by something else. For example, in the GI tract, the diarrhea and the abdominal cramping is often labeled as something related to IBS or a hiatal hernia, which is not uncommon, but in the patients with NETs, we also see diarrhea. The flushing or the rash can, if you don't know how to ask the questions, it might be interpreted, oh, you're just getting through menopause. If you have palpitations, someone might feel that you're having anxiety. If you are developing low blood sugars or high blood sugars, a provider that is not thinking about NETs might associate that with issues with your diet habits. If you're having mood changes, a provider might feel that this is related to depression and anxiety. And if you are having issues with electrolytes, when we check the blood, someone else might feel, oh, this is related to perhaps diarrhea, when it could be a completely different hormone that is causing the issue. So this is important to understand. But then let's take a step back and really focus on how we break down the symptoms, because we need to understand what is causing the symptom to try to fix the issue, right? And there's two approaches. One is understanding the symptom and going straight to address the symptom, to fix the symptom, or it's like, okay, we cannot really fix the primary issue, so we have to use a medication just to improve the symptom, but not eliminate the symptom. I tell my patients it's almost like a Band-Aid, right? We can make you feel better from the symptom, but I'm not necessarily fixing the symptom and making completely be gone. And then when we think about a cause, we have causes that are mechanical, that can be associated really of the tumor sitting on a particular place and causing issues because of the location. And we'll talk about symptoms that are related to the hormonal excretion that some of the neuroendocrine cancers can have, which is associated with a functional tumor. And it can also be a symptom related to a side effect of a treatment. And we'll talk a little bit more in detail about that. So let's think about mechanical issues and tumor burden. Here I have some figures that show about on your small bowel, either in the first one when you see a surgeon holding the gut there's a tiny little tumor that you can see there where it's a little bit more white. And that tumor is causing a little bit of on and off blockage. So a patient with that often have issues with sudden nausea, vomiting, and abdominal pain that can be severe with potentially some very strong diarrhea, and that can go away after a few hours or few days. How many times the patient may go to the ER and not have this detected? And then the patient can even have upper and lower endoscopies with their healthcare provider and not see these tumors because they're in the small bowel where the scopes don't get it. So this is someone that eventually, after having these episodes of on and off severe abdominal pain, nausea, vomiting, and diarrhea, there will be acute events that then will resolve. Eventually, the patient got diagnosed with a small bowel neuroendocrine tumor that was resected, and that issue resolved. In patients that are more advanced, they can develop these mesenteric masses that are fibrotic, and that can also be the rounded part here where the narrow is, and that can cause a lot of issues with obstructions on and off as well, and issues with the blood supply being drained there and then developing mesenteric ischemia. The picture of a surgical resection, you can see that there is an area of the gut that is darker than the rest. Is that this because this patient was suffering from mesenteric ischemia that led to issues with blood supply in the small bowel, and that eventually got resected. But that can cause a lot of pain, especially if that happens after a patient eats, and that can be related to mesenteric ischemia from the tumors that are anatomically sitting on your belly. And then in the last picture, you see a picture of a liver with a lot of liver tumors. And if they're pressing against the capsule of the liver, they can cause distension. And the patients will say that they have a lot of pain in the right side of the belly. And there are many reasons for that. But one of the reasons is that the tumors in the liver might be growing, causing distension of the capsule and causing discomfort. So is that a way that we can attack that for either resections or embolizations of these tumors to eliminate these issues? So these are some of the mechanical causes of symptoms in patients with neuroendocrine tumors, but there are many more. Then we can go to the hormonal symptoms, right? These are symptoms that happen because your tumor is producing a certain hormonal peptide that is causing symptoms. The most well-known is carcinoid syndrome. Is very much associated with serotonin and is associated with the flushing, the redness in the face, edema, abdominal pain, cramping, weight loss, wheezing as well. But there are many other hormones that can cause issues. For example, if someone is secreting ACTH, then you can have issues with electrolyte imbalances. Your sugars will be very high. You can have a lot of facing edema and so forth. If you have a tumor in the pancreas that is producing insulin, then you have severe and life-threatening potentially episodes of low blood sugars. And there are many more that it can be seen. So not every single patient will have carcinoid syndrome, and not every single hormonal symptom that you have is because of serotonin. There are many more that can cause this. So this is super important to talk to your healthcare team so they can decide how to approach, diagnose, and treat. And then finally, we have issues related to side effects of treatments. And one of the main ones that I think it's hard to see a patient that doesn't feel that a treatment is causing fatigue, right? Fatigue, the tumor itself can cause fatigue, but the treatments that we have can also cause fatigue. Some of them, the fatigue is only very shortly around the time of the treatment, but some of them can be very much chronic. Somatostatin analogs, even though they tend to be very well tolerated by patients, can cause fatigue. And there's many other symptoms that have been associated with the treatments. Rash, for example, if a patient is receiving everolimus or sunitinib, or even temozolomide with capecitabine, they might develop a rash. They can develop diarrhea from all these drugs because your white blood count might be decreased as a side effect of the treatment. You are much more susceptible for infections. You can have the redness in the hands and the feet, nausea and vomiting, headaches, including from somatostatin analogs. And I'm mentioning a lot somatostatin analogs because it's one of the treatments that we use the most, and certainly probably one of the treatments that patients will see first and might stay on the treatment for the rest of their lives, especially if they are functional tumors. And here is a list of described side effects that have been seen. A little bit of hyperglycemia. More rarely, we can see low blood sugars. Abdominal pain can be seen. A little bit of nausea, a little bit of diarrhea. Gallbladder stones, the fatigue, issues with malabsorption, and issues even with the thyroid. I say that the somatostatin analogs are hormones, and then they can make many of our glands in our body being lazy or hyperactive. So if it affects the thyroid, it can make your thyroid lazy and can develop hypothyroidism. If you affect your pancreas, it can even affect the sugars from up or down, or can affect how the pancreas produces enzymes that will help you to digest the food. And if you don't have that will be translating a symptom that's called steatorrhea, meaning that you have these mushy stools, they float, they can be oily, and you can have a lot of bloating with that as well. So let's talk about diarrhea because it's really the most common symptom that we have, and they can have so many causes. It's not just the carcinoid syndrome that is going to cause your diarrhea. So when you go and see your oncologist or whoever is taking care of you, and if they go and really keep asking you how is your poop, and they really try to understand how often do you poop, what's the consistency, does it float, what color, has the smell change or so forth, is because in their head they're trying to understand, is this a hormonal issue? Is this a mechanical issue because mesenteric ischemia can potentially cause the diarrhea? Or this is a side effect of the treatment that you are on? Or is this because we took so much gut that you have short gut? So it's important to be patient with your healthcare provider and really answer all these questions about how is your poop. Don't be upset with us if we keep asking. If you feel more comfortable not having a caregiver with you in the room, just ask your caregiver to leave for a little bit. I know that might be uncomfortable sometimes to talk about poop in front of others, but as your healthcare provider, it's our job to hear about your poop. And this is important, again, because we need to try to differentiate what is causing, because the diarrhea can be from this issue that is a side effect of the somatostatin analog, which is the pancreatic enzyme deficiency. And there are ways to diagnose, and there are treatments that we can do for that. If you have a large pancreas resection, or if your tumor is large in the pancreas, you might also have this issue because your pancreas function is not well. There are issues related to developing diarrhea because your gallbladder were removed, and then there are ways and medications that we can use if that's the case. There are issues sometimes because of post-surgery, you might develop an overgrowth of bacteria, and if that's the case, we can diagnose that and treat. There's obviously the hormonal issue as well. There's the issue of your gut being short and you don't have enough gut to absorb all the nutrients and the food just pass through, and that becomes the diarrhea. There's the issue with the ischemia. If you have a lot of mesenteric fibrosis and that's causing your gut not be functioning well and not receiving enough blood supply, that can cause diarrhea. So that is why it's so important to have this open communication with your healthcare team in terms of what are the symptoms that you are experiencing, and really go into detail of how are the symptoms. So if you say this is after meals or not, or before meals, that is actually because in our head, we are trying to understand, and I'm thinking here about mesenteric ischemia or not. So again, very important to have this open communication, because there are ways to decrease the burden of the symptoms, if hopefully even eliminate once we understand them. So my take-home points here are: do not assume your symptoms are caused by a particular reason. There could be many reasons. There can be all these reasons together. How many times patients come to me with the referral, oh, the diarrhea is from carcinoid syndrome. And then when we do this detailed workup, it turns out it's not. So it's very important to discuss again with your healthcare team and really answer all the questions and even volunteer more information. Be patient. Sometimes we're not going to be able to solve the symptom management improvement in one visit. It might take several visits to understand, especially if there are multiple symptoms or multiple causes of a particular symptom. And we'll strongly encourage everybody to consider including a supportive care expert in their healthcare team. In some places it's called supportive care. In some places it's called palliative care, because you have a palliative care doctor or supportive care doctor or provider in your team. It does not mean that that's because you are terminal and dying. The earlier data has shown that the earlier we involve a supportive care provider as part of your team, the better the patients will benefit. And there is not really this association that if someone is getting involved with supportive care is because they are dying. That's not the case. And I really want to take that stigma and this myth away from that. So consider including them. That's what I have. I really hope I was able to have a little bit of a breakdown of how to troubleshoot the causes of your symptoms and understand the importance of troubleshooting what is causing so we can treat it and not just use the Band-Aid approach. If you have nausea, I'll give you an anti-nausea medication. Perhaps if we identify what's the nausea from, we might be actually fix in the long term and not just give you a medication for the symptoms. So that's why it's so important to have that breakdown on your mind and your healthcare provider mind. Again, thank you so much, NETRF, for having me. You guys do a wonderful job for the community, and I'm really blessed to be part of your team of speakers today. Thank you.
Hi, my name is Luz Chavez, and I am the Manager of Clinical Nutrition and Diabetes Patient Education here at the University of Chicago Medicine. My specialty was also neuroendocrine tumors, and currently I educate new dietitians in that field. Today we will discuss nutrition specific for those with a neuroendocrine tumor diagnosis. Now, some of the advantages of making sure that you have proper nutrition during your treatments does include some of the following, and it is not all inclusive, but it's important to keep in mind that malnutrition is something that is occurring in high percentages among this patient population. Specifically in the outpatient center, about 14% of those with GI NETs do have a diagnosis of malnutrition. For those who are admitted into the hospital, the rate is closer to about 25%. Now, proper nutrition is specifically going to help maintain the well-being of these patients, specifically through the maintenance of lean muscle mass, which will then help maintain and support your immune system. It's also going to help manage a lot of those treatment side effects, because the stronger you are, the easier it is to tolerate some of those side effects. And because of all of these factors, it does overall help improve your quality of life, and as a result, your survival rate as well. Diarrhea is a common symptom that patients with symptomatic or asymptomatic NETs will experience depending on the treatment that they are having to go through. So to cover some of the general recommendations that you may receive from a registered dietitian that can apply to anybody is first, eating small and frequent meals. By having a smaller volume of food going through your digestive system, this is going to be much easier for digestion. Another common intervention would be increasing soluble fiber foods. Now, fiber can be a little confusing. There is a difference between soluble and insoluble, but the main thing to remember is that soluble fiber is going to be those foods that are going to help thicken your stool. So to break that down a little bit further, that's going to be your pectin-containing foods, which does include applesauce, and then bananas. Oatmeal can also be thickening, as well as potatoes, but specifically your white starchy potatoes. That starch, which you will also find in white rice, is thickening, whereas something like brown rice would actually speed up your stool transit time, which is not something you want to experience when you're already struggling with diarrhea. Another thing that you could consider if some of these interventions are not quite working is avoiding lactose-containing foods, and that would include not only things like yogurt, for example, but also milk products. You can also limit or avoid high-fat foods, which can be very aggravating when you're having diarrhea, as well as spicy foods. And these recommendations will be individualized to the patient because they may work for some and not for others. A key intervention with diarrhea, regardless of what is causing this issue, is to stay hydrated. At a minimum, you want to make sure you're taking in 8 to 10 cups of fluids daily. And in addition to that, you want an additional cup for each loose bowel movement that you have. When you're taking in large volumes of water to compensate for the diarrhea, you also want to consider adding an oral rehydration solution, which you can get over the counter and includes things like Pedialyte or even like diluted Gatorade. Now, what can add an additional level of complication for those with neuroendocrine tumors is carcinoid syndrome. So carcinoid syndrome is much more common in those with GI NETs and happens as a result of the tumor releasing serotonin. With carcinoid syndrome, you can see symptoms such as dry flushing, abdominal cramping, and even secretory diarrhea, which is very different compared to your everyday diarrhea. Secretory diarrhea differs in that it occurs multiple times daily. Many patients will often resort to restricting or eliminating food as a way to control their diarrhea, but if you were to attempt to do that with secretory diarrhea, you would notice that it would not stop this diarrhea from occurring. It can happen overnight while you're sleeping, and unfortunately, some of the more common over-the-counter antidiarrheals may not work for this type of diarrhea, and it can result in dehydration much faster. So electrolyte abnormalities can be common if you're not incorporating those oral rehydration solutions. With secretory diarrhea, you can still implement a lot of the common interventions that you would have for everyday diarrhea, such as consuming small frequent meals, making sure you're staying hydrated, and incorporating those pectin foods that I mentioned on the previous slide. The different interventions for this would include low amine diet and a high protein diet, which I will get into more detail on a later slide. First, to address dry flushing. It's one of the most common symptoms that patients will experience with carcinoid syndrome. Now, like it says in the name, dry flushing means that there's no perspiration. So I've often had women ask, I'm going through, hot flashes because of menopause, what is the difference, so that they can identify that difference when they're keeping track in their symptom book. Just remembering that the dry flushing really does not have any kind of perspiration associated with it, and you may just notice your face feeling hot and flushed. Dry flushing can unfortunately be worsened by what we refer to as like the 5 E's, which is eating, epinephrine, your emotions, ethanol or alcohol, and exercise. Some nutrition interventions for dry flushing is going to include avoiding larger meals. So once again, small and frequent meals is going to be very beneficial for the symptom. As I mentioned before, ethanol or alcohol can be a trigger. Spicy foods can also be a trigger. And then in order to improve your outcomes, we want to make sure you're focusing on a high protein diet and a low amine diet. And one thing to remember when you're consulting with your physician or your dietitian is that your recommendations may look very different than somebody else who has a NETS diagnosis. So as I mentioned before, a low amine diet is a very common intervention when you have carcinoid syndrome, regardless of the symptoms that you're having. Now, amines, which does include tyramine and dopamine, are amines that are found in foods. Now, the significance of this is that tyramine and dopamine can increase catecholamine production. Now, what this means basically for those with a NETS diagnosis is that these amines increase secretion of serotonin. If you have an increase of serotonin, this is going to cause an excess of symptoms. So some of the foods that you could consider minimizing or eliminating are on this table. And I will say that it is not all inclusive. And for many patients, they may find that they do not need to eliminate or reduce all of these foods. It is very individualized, and each patient will find that we have to go through this list and kind of, trial and error figure out which is the one that is influencing their symptoms the most. So once again, I'll definitely echo that it's important to meet with a registered dietitian to kind of help you through the process of figuring out what your triggers are. Now, I've also mentioned a few times that a high protein diet is really important. Now, this all goes back to that serotonin production. Tryptophan, which is considered an essential amino acid, which you can only find in complete proteins, and it's not made in your body. So you have to get it from outside foods. The tryptophan is a precursor to serotonin. So if your tumor is producing a lot of serotonin, that means that it is taking a lot of tryptophan from your body that you need for other functions. And one of the main things that you really need tryptophan for is not only to produce other proteins, but to produce niacin, which is really important. So some foods that do contain tryptophan are things like plant proteins, and then you also have chicken, turkey, your eggs, and then sunflower, pumpkin seeds, peanuts, and soybeans. Now, things to look out for with the niacin deficiency. I will say that one of the most common symptoms that those with NETS may see is going to be what we refer to as dermatitis. So that's going to be scaly brown patches that are on your arms and legs. And in my practice, I will say that I have caught this a handful of times. Now, if the niacin deficiency does go undiagnosed, it may progress to a more serious diagnosis, which we refer to as pellagra, which can include things like diarrhea, worsening diarrhea, dementia, depression, nervousness, and in very serious cases, I will say that pellagra can also lead to death. However, in our NETS population, we typically see that dermatitis occur. Now, a thing to keep in mind that if you're also losing weight and your appetite is really poor because of your symptoms and you're taking in very little food, this is only going to further contribute to the niacin deficiency. So it's really important to get that consultation with your registered dietitian so they can help with some interventions to prevent this. So treating niacin deficiency is actually pretty straightforward, I will say. You can treat with niacin supplementation, which would include niacinamide, about 20 to 50 milligrams twice a day. You can also find it sometimes in a multivitamin. But if you do have a niacin deficiency, we're going to recommend that high protein diet, that multivitamin, and a niacin supplementation. And some things that your dietitian may ask you about is if you've been experiencing a lot of weight loss, any kind of flushing, if you have a history of poor appetite. And then we'll also take a look at your labs to see if you have that elevated serotonin level that would be causing tryptophan to be used for that serotonin production. Now, some natural food sources of niacin that can be included in your diet is going to be some of those animal proteins. chicken, beef, and fish, and liver are going to be your highest sources. In terms of fruits, avocados, dates, and passion fruit are actually higher in niacin. And then in terms of veggies, you have your mushrooms, your broccoli, and your asparagus. And all of those can be incorporated into your diet, as well as some of the supplementation. Now, to kind of help consolidate all of these different recommendations, if you have symptomatic NETs, we want to make sure that you get a consult with an oncology dietitian. Most oncology centers do have an oncology dietitian on site, so you can request a referral from your oncologist to get plugged in with that person. If they don't happen to have an oncology dietitian, they will typically at least have a referral process in place. Once again, we want to make sure you're focusing on the high protein diet in order to minimize your risk of niacin deficiency, but also just to help support your immune system and maintain your muscle mass. Decreasing fat, because that can be very irritating and can worsen your diarrhea symptoms. You want to make sure you're staying hydrated as well. And if you have diarrhea, you want to make sure that you're including drinks with electrolytes, such as Pedialyte. You may want to consider decreasing added sugar, as that can worsen diarrhea, but also cause worsening in carcinoid syndrome symptoms. Can limit and avoid spicy foods, once again for the diarrhea, or just to reduce your risk of carcinoid syndrome symptoms. And then if none of these interventions work, that's where you want to work with your oncology dietitian and limit high amine foods to further improve your dry flushing and secretory diarrhea. And then, of course, considering a niacin supplementation just to make sure that we reduce that risk of dermatitis. Thank you.
Next, we are going to focus on genetics and fertility. These are topics of concern for many NET patients and their families, and we get a lot of questions about these topics. Dr. Mark Lewis will discuss genetics, and Feighanne Hathaway, a genetic counselor from University of Chicago Medicine, will talk about genetic testing, what it is and what it can tell us.
Hello, everyone. My name is Dr. Mark Lewis. I'm the Director of GI Oncology at Intermountain Healthcare, based in Salt Lake City, Utah, and I'll be speaking today with Feighanne Hathaway from the University of Chicago on the subject of genetics and fertility, and I believe I get to lead off with a discussion of genetics in NETs. So the first thing to point out is that I think there's a lot of confusion between the term genetic and the term hereditary. What I'm interested in primarily in this talk is talking about the rare or few cases of neuroendocrine tumors that are actually a result of hereditary mutations. So what you have to realize is on some level, all cancer is genetic. All cancer arises, we believe, from a mutation or an error in our genetic code. What we're talking about today, though, is those instances where that mutation is actually inherited from one of your other family members. So for reasons that will become quickly evident, I'm going to use multiple endocrine neoplasia type 1 as an example. So what I'm trying to show you here is that the human genome, our genetic code, is 3 billion letters long, and to an almost frightening degree, a tiny mistake in that long sequence of letters, A, C, G, and T, repeated over and over and over again, can give you genetic conditions. So multiple endocrine neoplasia type 1, we've known since 1997. This condition, which I'll explain more in a minute, is actually arising from mutations in only a 7,000 or so letter sequence on the long arm of chromosome 11. So we have 23 pairs of chromosomes, and this occurs on the 11th chromosome. So again, what's really the issue here is the mutation occurring only in the tumor, what we would call a sporadic mutation, or is it actually occurring in the patient? So one example I would give you from math, I've been teaching my son algebra here recently. So every square is a rectangle. Not every rectangle is a square. What I mean by that is, as I said earlier, all cancer is genetic. Not all genetic mutations are hereditary. So what we're interested in here is parsing out, is the mutation only occurring in the tumor, sporadic, or did the mutation actually come from the patient's parents? And the reason I picked MEN1, if we look at pancreatic neuroendocrine tumors and take all comers, about 40% of PNETs will contain the MEN1 mutation. However, only a tiny fraction of those actually reflect the fact that the patient themselves has the MEN1 syndrome. So this is something called the two-hit hypothesis. This was first discovered or postulated by Dr. Knudsen. And it's one of the key things to understand is that if you've got 2 copies of every gene and you inherit a faulty one from one of your parents, you have what we call loss of heterozygosity. And that means you're basically living on a thread. You're living on the good copy of that gene until it in turn gets mutated somewhere in your lifetime. And that's how MEN1 patients in particular develop tumors later in life. Okay, so now I'm going to move quickly through a variety of hereditary syndromes. Again, each one of these is pretty rare. Multiple endocrine neoplasia type 1 affects maybe 1 in 20,000 to 30,000 families in the United States. It's an autosomal dominant condition. I'll explain more of that in a minute. And it's really recognized by the 3 Ps. So the 3 Ps are pituitary, thyroid, and pancreas, the 3 glands that are most affected. 3P mnemonic is great, but it doesn't capture some of the other, frankly, more deadly forms of this disease where MEN1 patients are also prone to develop carcinoid tumors or sometimes neuroendocrine cancers in their chest, whether it comes from the lungs or a gland behind the breastbone called the thymus. And then finally, and almost cosmetically, one of the key features of MEN1 is these little red bumps on the nose and the midface that can be quite painful and they can even bleed. They're called angiofibromas. So all told, if you add up in the pie graph on the right, you'll see that the vast majority of MEN1 patients fall into one of the 3P categories. But there are these rarer manifestations that can be easily missed even by very experienced doctors. And so again, think beyond the 3Ps when it comes to MEN1. So MEN2 is actually a completely different syndrome coming from a mutation on chromosome 10. It does bear some similarities to MEN1 in regards to hyperparathyroidism, but otherwise it looks completely different. So MEN2 has 2 distinct variants. MEN2A is medullary thyroid cancer, pheochromocytoma, and the hyperparathyroidism. MEN2B is the medullary thyroid cancer, pheochromocytoma, but then it has some very distinct facial features. So specifically, we're looking for bumps around the mouth and on the tongue. Finally, we've realized in the last couple of years that some patients actually have this sort of combination of the 2 syndromes, and it's called MEN4. And again, what was happening is patients were coming to us and they looked like they had MEN1, but when we just examined that MEN1 gene, which again is on chromosome 11, we didn't find anything. And the reason for that is there's actually a completely separate mutation that occurs again on another chromosome. And now we're talking about chromosome 12. So what this shows you is that MEN1 and MEN2 basically are spliced together here to form MEN4. These patients are affected by primary hyperparathyroidism. They're prone to pituitary tumors, but they also get the adrenal tumors like we see in MEN2. And then finally, they can get carcinoids and PNETs, and women can even get a very aggressive form of cervical cancer. So moving along, von Hippel-Lindau syndrome, sometimes known as VHL, again is autosomal dominant and occurs on chromosome 3. Here are the manifestations of VHL. You'll notice that the non-eponym version of this is not exactly something that rolls off the tongue. Familial cerebelloretinal angiomatosis. Basically, this means that you can get these very vascular tumors happening everywhere from the eye to the part of your brain that controls balance, to down your spinal cord, to your adrenal gland, to your kidneys, and even to your pancreas. The last couple of years, in fact, there is a medicine that is specifically approved, it's called belzutifan, for patients who develop tumors from VHL. So it's a landmark approval by the FDA because now we have a treatment that is linked to a genetic syndrome. And at least in my GI oncology practice, that's one of the first times that's happened. So what about too much adrenaline? So it turns out you can have too much of a good thing if your adrenal glands, or sort of the conduit of cells that produce adrenaline elsewhere in your body, if they become mutated, you can get something called a pheochromocytoma, often shortened to pheo, or a paraganglioma. And the top 3 ways this manifests in patients are really severe headaches, and usually at the same time, sweating and the pulse racing. And that triad tells us that there's too much adrenaline. So what I'm showing you here is most adrenaline in the body, as the name would suggest, comes from the adrenal glands. But about 10 or 15% comes from this chain of adrenal-like tissue that can occur elsewhere in the body, and those are called paragangliomas. Anyone who has a pheochromocytoma or paraganglioma should undergo genetic testing to rule out a family of mutations that we call SDHX, or succinate dehydrogenase mutations. Okay, I promise we're getting to the end of the syndromes, then I'll get into some more general points. So neurofibromatosis. So what I'm showing you here are 3 different aspects that you can see visibly on the surface of a patient that has neurofibromatosis type 1. So the top right, what you're seeing there are what we call cafe au lait spots. So almost like you've spilled coffee on the skin. You get these brown, pretty flat areas on the skin. We have a zoomed in picture of an eye, and what we're showing you there are what are called Lish nodules. These little bumps that happen on the iris. So sometimes a good ophthalmologist will pick this up. And then finally, the neurofibromas of NF1 are these usually benign sort of nerve tumors, but if you look at the bottom right, they can be absolutely profound on the surface of the body, and as you can imagine, it can be quite disfiguring. So I'm happy to say over the last couple of years, we have some new treatments that also address those tumors. So tuberous sclerosis is interesting because it can actually come from two different mutations, depending on which chromosome you're on, chromosome 9 or chromosome 16. And again, remember, there's 23 pairs of chromosomes in all. So what I'm showing you here are all the visual manifestations. So there, you can see top right, there's a pearless patch on this person's back that's called an ash leaf spot. In the middle, there's a leathery appearance to the skin that's called a shagreen patch. And then finally, this name is right on point, it's called a forehead fibrous plaque. It feels like kind of almost like a raised scar on the forehead. And all of these are the skin manifestations of tuberous sclerosis. Finally, though, and relevant to NETRF, these can cause neuroendocrine tumors, and specifically in the pancreas, and they can look quite cystic. We're going to get out of the weeds and take a 30,000-foot view. Why does this all matter? So if you know a given patient has a genetic condition, they're going to have that the rest of their life, and that affects how you follow them. So for instance, for an MEN1 patient, I'm very, very eager to minimize their radiation exposure. I don't want them getting CTs every year because over time that adds up to be a lot of x-rays. So I prefer MRI for most of the patients I'm following lifelong with these conditions. So the tip of the iceberg phenomenon. Because of the inheritance patterns of these syndromes, if you can find one person who's affected, you can find multiple other family members. My best example of this is when I was training at the Mayo Clinic. I identified for the first time in a family, a grandfather had MEN1. There's a large family, so when we went and tested all of his relatives, sort of a cascade, we found the full half of them. So 20 people out of the 40 people that we tested had MEN1 as well. And that, of course, is going to affect how they are followed by their doctors. So again, it doesn't just matter for the person in front of you, it matters for their whole family. Okay, so finally, as I was mentioning earlier, you can see some uncommon presentations of even rare diseases. So this x-ray holds a lot of meaning to me. This is the x-ray of an MEN1 patient. You do not have to be a doctor or radiologist to see the problem here. So the top right, remember this is flipped, so what's on your left is actually the patient's right lung. You can see this huge mass up in the top of the right lung. This is my father's x-ray. This is the x-ray he received when we immigrated from Scotland to the United States as part of public health. Everyone coming to this country gets an x-ray to make sure they don't have tuberculosis. My dad didn't have TB, but he had this huge mass in his lung that he didn't know about. So this is one of the manifestations that does not fit in the 3P mnemonic. This is a bronchial carcinoid, and this ended up killing my father. So you might imagine it makes me a little bit emotional, to say the least, to recognize that not all of these patterns necessarily fit nicely in things that we can remember. So just know that if you have a feature of a syndrome that fits outside the mnemonic, that's still very valid, and you can still bring your concerns to your doctor. So let's finish up with a pedigree. So a pedigree is what we call basically a medical grade family tree. So I'm showing you here is my own family. And I've started at the top by saying family history is never non-contributory. I put that in quotes or maybe even air quotes. That's something that you might see in your medical record. And generally what it means is your doctor didn't even take your family history. But in oncology, it matters a whole lot to know with as much detail as possible what affected your relatives and when. So looking back the way, I can see that my father's diagnosis, his high calcium level, which stemmed from hyperparathyroidism, and similar problems affecting my dad's side of the family, that was all MEN1. Although, frankly, I was the first person in my family to recognize that we had it, so this has all been reconstructed retroactively. So this is how I first learned about MEN1 in the textbook. It's classic autosomal dominance. What was happening here is a very astute doctor, an endocrinologist in New York City in the 1950s, was taking care of a family of Italian immigrants. And half of them were dying from stomach ulcers. Now that may sound very odd. Like, why would that be happening? The reason it was happening is that in MEN1, whether it was men or women, those unfortunate people who inherited the mutations from their parents, which you can see here, they're the squares and circles that are either blacked out or grayed out, those people had a predisposition to stomach ulcers that would either bleed or perforate, meaning create a hole in the stomach, and those were often fatal events. So prior to 1990 and the advent of drugs like omeprazole, the PPIs, Nexium, for instance, people were dying left and right of that particular stomach ulcer problem. So this is how I first encountered MEN1 in a textbook. And basically what it means is a 50-50 chance that you're going to get the syndrome if your parent has it. And this is how it looks to me now. These are my kids. So it's one thing to look at an abstract diagram in a textbook and say, oh, isn't that interesting? It's completely another when it's your life and it's your family. So I have 2 children. Happy to say you can't tell by looking at them who's got MEN1 and who doesn't. But this is my final illustration of 50-50 inheritance under the autosomal dominant model. My son inherited it from me, and my daughter didn't. And I'm okay with that, but I think as we get into the fertility discussions, I think this affects how people approach family planning, and specifically the area of reproductive endocrinology, and I'll defer to my partner to talk about that in the fertility section. But I just know this is very real to me. This is not diagrams and textbooks, this is real life. And the family aspect of it absolutely matters, but thankfully it's the minority of NET patients that actually have to deal with hereditary mutations. So in closing, I want to thank you. This is definitely a community that has supported me through some very difficult times. And I'd be remiss not to note that my greatest support has actually not come from a blood relative. It's come from my wife, who has literally sustained me through some of the darkest and most difficult days of my disease course. So on the left, you can see me in the morning of my Whipple surgery, where I had half my pancreas removed. In the middle, when I got out of the hospital a week later. And 5 weeks later on the right is when that tube was finally removed from my nose. And boy, that was one of the most joyous moments of my entire life. So have a great conference.
Hi, I'm Feighanne Hathaway. I'm a board-certified genetic counselor from the University of Chicago, and I'm grateful to be talking to you today a little bit about the genetics of neuroendocrine tumors. For those of you that don't know what a board-certified genetic counselor is, we provide patients with a little information about what genetics is, how it plays a role in your cancer diagnosis, and so I'm going to explain a little bit about that today. So to begin with, all cancer is actually genetic. In order for you to get cancer, you have to have genetic changes occur. And when I'm talking about genes, and this is an example of our cell, in our cell we have chromosomes, and on the chromosomes we have genes. We have many different genes that do many different things in our body, including they make our eye color, our hair color. But what I'm referring to are the genes that actually, their job is to protect us against getting cancer. Those specific genes are called DNA repair genes and tumor suppressor genes. And if they're not working properly in our body, if we've inherited a copy from our parents that doesn't work properly, that can put us at higher risk for getting cancer. I'm going to explain this a little bit later on in more detail. So what is the big difference between when somebody gets an acquired mutation, so something that happens as they get older, and a germline mutation, so something that you're born with? So all those tumor suppressor genes that we were talking about, we get one copy from our moms and we get one copy from our dads. If both copies are working, that's great. And you can go through life, but then they can actually get knocked out as we proceed with life. Some people, though, are actually born with one copy already not working from either mom or for dad. So when we're referring to cancer genetics, there's 2 types of cancer genetics. There's germline mutations, and then there's also somatic mutations. And again, all cancer is genetic in the sense that you have to have genetic changes occur in order for you to get the cancer. And those are all somatic hits, or hits that are occurring within a particular cell that can actually grow out of control, and that's actually what causes cancer. So to give you a little bit more information about this, so tumor suppressor genes and DNA repair genes, again, we inherit both copies from our moms and from our dads. So we inherit a copy from mom, we inherit a copy from dad. As we get older, just by the normal aging process, some of them can get hit and knocked out. And in that particular cell, that gene is no longer working. But you have that backup copy, so you're okay. And as long as that backup copy is working, then you won't get cancer. But what happens when that backup copy also gets knocked out? Well, now you have no backup copy and you get the cancer diagnosis. So that's your typical sporadic cancers. Then on the other hand, we have hereditary forms of cancer. And the hereditary is you're already born in every cell of your body with a copy that's already not functioning. And so as long as that backup copy that works and does its job, you'll never get cancer. But what happens again if that one gets knocked out? Well, now you can develop cancer. So this process is actually the same as far as cancer development goes. It just happens a little bit quicker for hereditary forms of cancer. I've been doing this for about 20 years now, and the role of genetics has changed dramatically. When I first started doing cancer genetic counseling, we were looking at 1 or 2 genes at the most. We had to do testing. Testing could cost up to $5,000. Now we do testing, and we can actually do genetic testing looking at the tumor itself and also looking at your blood, so looking at germline genetics. My role has expanded exponentially. I'm really excited about it, and I think it's created many opportunities for patients to actually undergo different treatment options. But we can also inform family members about risk and also offer family members a reduced risk assessment. So what are these things that I'm talking about? Well, these are the 3 types of cancer that you can get. You can get what we call sporadic cancer. So that's someone who actually, if you see down at the bottom, who gets a breast cancer diagnosis in 60. So we know that, for example, in breast cancer, 1 in 8 women will get a form of cancer. And so when you get it in your 60s, that's considered a typical diagnosis, usually done due to the environment or random genetic changes that you've acquired. Familial cancer, the difference between that, makes up about 10% of all cancers. That's usually 1 generational. So you'll see this in families that might live in a hot spot for getting cancer. And so it's a combination of their genes and their environment, but you won't see the multiple generations. You won't see the younger age of diagnosis. On the other hand, then we have the hereditary cancer forms. This is where I come in. Most cancers do not fall in this, so only about 5 to 10% of all cancers actually will fall into this category. And it tends to be a younger age of diagnosis. So that goes, for example, for breast cancer, 45. For neuroendocrine tumors, it's also going to be around under the age of 50. So anything under the age of 50 is considered an early onset diagnosis. And then also the rare cancers. So in this example, it's showing you an ovarian cancer. Only 1 to 2% of the population will get an ovarian cancer. So when you see that, you kind of go, well, why is that? In the neuroendocrine world, a pheochromocytoma actually is considered a rare cancer diagnosis. So when we see that, we automatically go, well, maybe this person is at higher risk for a hereditary form of cancer rather than just the random sporadic cancers. So what are the hereditary cancer syndromes specific to neuroendocrine tumors? When we have a pancreatic and a GI syndromes, we have MEN1 and von Hippel-Lindau. And then when we have the pheochromocytomas and the paragangliomas, we also have von Hippel-Lindau, MEN2, neurofibromatosis. And then there's this new category of genetic syndromes called hereditary paraganglioma and pheochromocytoma syndrome. And I'm going to go into the details of this a little bit. Medullary endocrine neoplasm, MEN, is divided into 2 categories. We have MEN1, we have MEN2, and then MEN2 is actually divided into 2 more subtypes. MEN1 has a prevalence of about 1 in 10 to 100,000, and it involves 2 of 3 specific criterias: a parathyroid tumor, a pancreatic insulinoma, and a pituitary tumor. All of these conditions are what we call autosomal dominant, meaning males or females can carry these. It's about 90% inherited. So if somebody is diagnosed with this syndrome, they know that they probably got it from mom or dad. But then 10% is what we call de novo, meaning it could have just happened in the child at the time of conception. Mutations in MEN1 are typically just in the MEN1 gene, 95% of the time, but about 5% of the time we might not be able to find the genetic change. MEN2 and how this is different is a much higher prevalence, about 1 in 35,000. And these involve thyroid cancer about 95% of the time, a parathyroid adenoma, a pheochromocytoma. 5% of MEN2A is de novo, meaning 95% of MEN2A is inherited. The difference between an MEN2A and an MEN2B is that in MEN2B, it includes all the same cancers, but it has a specific phenotype. It's called a marfanoid-like phenotype, meaning that an individual can be taller than average, taller than their parents. They have a longer wingspan than typical, and it's usually because it actually affects their collagen. 50% of those are de novo, so that usually happens at conception, and some people don't even know they have this syndrome. So that's one association. The second association that we have is von Hippel-Lindau, or VHL. VHL is the actual gene that is associated with this particular syndrome. It has an incidence of about 1 in 32,000. It's also autosomal dominant, again, meaning mom or dad can carry it. And it has about a 20% de novo rate. These individuals are at risk for adrenal gland tumors, the pheochromocytomas, pancreatic tumors, kidney cancer. They can also have a retinal angioma, sometimes some brain tumors, and spinal cord tumors. Mutations in the VHL account for about 100% of all VHL. So usually if you have this disease, we can find a mutation that's causing it. The third neuroendocrine tumor that can be associated is a condition called neurofibromatosis. This is usually diagnosed actually in childhood. It has an association with pheochromocytomas, but typically it will have all these other clinical diagnoses like cafe au lait spots, Lisch nodules in the eyes, skin fold freckling, so under the armpits, and then many neurofibromas on the skin. You can have hundreds to thousands of these neurofibromas that are on the skin. So typically you see this in childhood. Then the newer category of genes is the succinate dehydrogenase syndromes. These can be associated with all of these particular 5 other genes, SDHA, SDHB, SDHC, SDHD, and SDHAF2. 1 to 10% of all sporadic pheochromocytomas and paragangliomas can be associated with the syndrome. And then about 20 to 30% of what we think are inherited can be associated, we'll be able to find one of these genetic changes. The clinical manifestations are, again, just pheochromocytomas and paragangliomas. To kind of go over what a pheochromocytoma is, it's usually a benign tumor of the adrenal gland, and a paraganglioma is a benign tumor near the nerve and blood vessels. So the signs or symptoms can actually be hypertension. You can usually sometimes end up with headaches, sweating, heart palpitations. So sometimes when I'm taking a family history, I usually will say, did anybody suddenly die in your family of a sudden stroke or heart attack? Does anybody have any panic attacks? Because all of that can be manifested in this particular syndrome. The red flags for neuroendocrine tumors is any diagnosis under the age of 50, and then any weird cancers. So that pheochromocytomas, again, it doesn't matter what age of diagnosis. In that case, we would automatically want you to see a genetic counselor to see if it's hereditary type. A paraganglioma by itself is also an indication. And then any diagnosis of any pancreatic tumor, whether it's a neuroendocrine tumor or not, is actually going to be warrant a genetic testing. So that's usually one of the number one concerns of a lot of my patients is, what about my kids? We do test children for all these conditions because screening for these conditions will actually happen at a very young age, even at birth. Can I avoid having a child with this syndrome? What is the risk to have this condition? So because this is autosomal dominant, all these conditions, that means that your children will have a 50-50 chance of inheriting the syndrome. So meaning you can pass on the one copy of the gene that's working, or you can pass on the copy that's not working. If you want to avoid having a child with this condition, you can go through a process called PGD, or pre-implantation genetic diagnosis. And what that involves is IVF. And they select the embryo that doesn't carry the mutation, and they put that in as opposed to the embryo that might be carrying that. So that's a way of avoiding having a child with the condition, or reducing the likelihood. And another way, obviously, is just to know ahead of time whether the child has the condition, is to do typical prenatal genetic testing. You can do that through amniocentesis, even if you just wanted to know upfront whether or not your child had it before they were born.
At NETRF, we talk a lot about thrivership, the state of knowing what you need in your personal journey to thrive after cancer treatment, and what survivorship looks like for you. Quality of life is hope in action and an area of research. Our Director of Patient Education, Jessica Thomas, has practical thrivership strategies. Dr. Simron Singh, an oncologist at Odette Cancer Center at Sunnybrook Research Institute in Toronto, will discuss quality of life research.
Hi, I'm Jessica Thomas, Director of Patient Education for the Neuroendocrine Tumor Research Foundation. I am here to talk with you about hope in action, living well with NETs through NET Thrivership. But to talk about a NET Thrivership journey, we have to identify what is Thrivership, and maybe perhaps what it's not. NET Thrivership is a personal journey. It's a lifelong process, and it begins at the diagnosis and continues throughout life. It's individual. It varies for each person, and it really may include physical, emotional, and social aspects, so it's different for everyone. It's hopeful. It's focused on living well beyond cancer, embracing life with optimism. It's supported and often involves medical follow-up, rehabilitation, and support, and multidisciplinary care. It's empowering. It encourages self-care, advocacy, and lifestyle adjustments for wellness. And it's changing and challenging at times. But what net thrivership is not, is it's not temporary. It's not uniform. It's not isolated. It's not defeating. It's not something we should ignore. And it's not something that's very well defined. So what are the components of net thrivership? I think essentially they're a recipe. And one of the things that is in net thrivership are things that we can't control. And that may be nets or necs. It may be the grief that is a part of your journey. It may be changes that you experience, treatments, and symptoms. And so those things are going to automatically be a part of your net journey. But the other things are the fun things, the things that you can control, the things that you can add in to help to live well with nets. So a couple of these things are gratitude, sleep, utilizing resources, having a holistic approach, positive psychology, being connected with others, managing your symptoms, having aspects of emotional wellness, exercise, nutrition, stress management, finding purpose, managing uncertainty, professional support, building a support system, and hanging on to what matters most. Also, resilience building is a part of net thrivership, and I'm going to focus on a little bit of resilience as I continue to talk about thrivership today. But before we do that, I want to talk about worry versus care. I want to help you get into a place of control. And we can control not being in a place of worry and moving to a place of care. Worry can be difficult because it's really charged on negative emotions and potential negative outcomes, while care is rooted in the present moment and the actions that you can take now. Worry can tend to create a sense of anxiety, whereas care can give you a sense of control. And so I want to give you the permission, if you find yourself worrying, to know that you can move yourself to a place of care, and that's empowering, and that is something that you can control. Next, we're going to talk about NEST. This is an acronym I learned at a recent conference I attended on happiness, and I thought it fit really well with a NEC population. When we think about our foundation, we should think about our NEST. How is our nutrition? Are we eating well? How is your exercise? Movement is so important for you on a physical level, but also on a psychological level. And exercise looks different from person to person, but movement, are you moving? How is your sleep? Sleep helps us to reset. Sleep also can help us with fatigue. And then there's touch. And so for touch, I think of holding hands or hugs, but also I think beyond that, I think it means more connection. Are we connected with others? So thinking of these as 4 primary things that we should have in our thrivership journey and NEST. We're going to move on to some resilience building strategies. And the first one is a mindset tool. Now, if you have followed me at all in the Net Thrivership series, you would see that I talk a lot about gratitude, because gratitude can help us to rewrite experiences and help us to find some of the good and the positive. It doesn't override, though, the difficult things that happen. They're still there. Another strategy for gratitude is glimmering. This is something that a patient shared with me a little bit ago, and I just think it's fantastic. So as you go through your day, what are the little things that were little glimmers? Things that made you happy, made you smile? More than likely, they were small things. So as you end your day, think about the things that glimmered for you throughout the day. And then there's unfortunately, fortunately. And I like this concept because bad things happen and unfortunate things happen, and we don't need to discount them. So we can talk about difficult things that happened by saying, unfortunately, this happened, but then finding the fortunate part. For example, if I was running late to a doctor's appointment, unfortunately, I was running late to a doctor's appointment, but fortunately, I was able to listen to a song that reminded me of a time when I was really happy. Accepting your emotions can be very helpful, and there's no bad or wrong emotions to feel. So for this micro practice, I'm going to lead us through how to do this, and I hope that you'll get something from it and repeat it in the future. So for this micro practice, I want you to find a quiet space. I want you to sit comfortably, and I want you to close your eyes. Take in a few deep breaths. When you inhale, breathe in through your nose. Hold your breath for just a second, and then exhale through your mouth. Do this for a couple of times just to help you get centered. Now we're going to bring our mind to any emotions that you might be feeling that are present with you right now. And I want you to acknowledge them without any judgment, whether it's fear, sadness, frustration, overwhelm, or maybe even excitement, calm, or hope. I want you to observe the sensations that you feel. Notice any physical sensations with these emotions. It could be tension in your body, a lump in your throat, a feeling of warmth, or even a feeling of heaviness. Allow yourself to fully feel these sensations without trying to change or resist them. As you continue to breathe slowly and deeply, remind yourself that emotions are a natural part of the human experience. There's no right or wrong way to feel. Embrace each emotion as it arises, accepting it with kindness and compassion. Next, take a moment to reflect on how practicing acceptance of your emotions makes you feel. Notice any shifts in your awareness or emotional state. When you're ready, gently release any lingering tension, discomfort with each exhale. And then we finish this micro practice by expressing gratitude for the moment of self-awareness and acceptance, for the ability to give ourselves time and space to feel what we are feeling. So for this last resilience building activity, we're going to focus on connection. I'm going to go to the conference that I attended recently. The presenter asked everyone to take their phone out, and I'm going to ask for you to do the same thing if your phone is available. If not, you can do this exercise later. But I want you to reach out to one or two connections, one or two contacts in your phone. Maybe somebody you've missed talking to, maybe somebody you've wanted to connect with, or maybe someone that you've had a hard time just saying hi because you've been so busy. I want you to take a moment to do that right now. Say hi, thinking of you. How are you doing? I would love to schedule a time to talk, whatever feels comfortable. And so the purpose of this activity is to initiate connection, because connection fuels us, and it's a very important part of our Thrivership journey. NETRF is dedicated to help you in your Thrivership journey, and we have a whole lot of Thrivership resources for you. You can see in the middle of the screen there is a QR code. And there, if you scan the QR code, it will take you to our NET Knowledge Center. And our NET Knowledge Center will bring you to resources to sign up for our NET Patient Guide, to listen to our NetWise podcast, to see our NET Thrivership series, as well as being able to sign up for conferences such as the Know Your Nets conference. Please know that we have a lot of resources and that we're here for you in your Thrivership journey. And I'll end with this. You matter. Your journey matters. You are not alone. And we care at NETRF. My contact information is on the screen, and you can feel free to reach out with any questions that you may have, or if you just want more Thrivership resources during your NET journey.
Hi there, I'm Simron Singh. I'm a professor of medicine at the University of Toronto in Toronto, Canada, and also a co-founder of the Susan Leslie Clinic for Neuroendocrine Cancers. I'm a medical oncologist with a special interest and specialization in neuroendocrine cancers. Early in my career as an oncologist, I think what's really become important to me is there's two things that as an oncologist and a patient team we can work towards together. One is to improve the quantity of life, and the second is to improve the quality of life. So live longer or live better. And those are the two goals that I think I share with my patients. So when it comes to live better, we know that many patients with neuroendocrine cancer are going to be living with this disease for a period of time. Hopefully we can start thinking of this like a chronic disease, like we think of diabetes, we think of people who have osteoarthritis. People live with these diseases. So for me, and I think for many of my patients, quality of life really means living with neuroendocrine cancer and living their best life possible as symptom-free and as high functionality as they can be, to ensure that they can go on with their lives, the things that are important to them, while dealing with the neuroendocrine cancer. Quality of life is a really big umbrella. Now when we do clinical studies, we have very standardized tools that are used, and they're used between different studies, and they're measuring quality of life the same way. But there's more to that. There's also something called patient-reported outcomes, where we want to understand what's the impact of the disease and of the treatment on patients' life. One of the larger studies that we've done is really asking patients directly around the world, how does neuroendocrine cancers affect your life? And it does. It affects their ability to work. It affects their ability to do the things that they enjoy with their family and friends. It affects their energy levels. And it can have impact on their families and their caregivers. So I think understanding all of that is very important. And most recently, what we've been doing is ensuring that as we develop new treatments for neuroendocrine cancer, that we include the impact not only on how long the new treatments help people live, but how well they help people live during that time period. And make sure that we include these as very important parts of development of any new drugs or treatments. The final piece I'll add is we also have to do a better job at trying to understand what's important for patients, and that could be different. We've done some studies on what's called a discrete choice experiment, where we actually ask patients, based on your disease and based on these choices of treatments that you may have, what's right for you when we compare that live better, live longer? How does those things affect you and your values, and how in fact does that ensure that you're living the way you want to live with this disease? Unfortunately, many patients with neuroendocrine cancers have what we call functional syndrome, which means they have secreting hormones, and those hormones can cause different symptoms: abdominal pain, bloating, flushing, diarrhea, fatigue. So I think, first of all, telling us about those common symptoms that we are often asked about as neuroendocrine patients and providers, the flushing, the diarrhea, is important. But I think the other thing that people can do is tell us about how this disease is impacting their daily life. I often ask my patients, tell me about what an average day for you is like. What time are you getting up? How are you spending your day? Are you able to achieve the activities that you want to achieve? Are you able to meet things such as meals and laundry, or do you need help with that? Are you able to find the help that you need with that? So I think telling people about how the disease is impacting your life, how you want to be living your life, and how the disease is holding you back or the treatments are holding you back, I think is really important to share with your provider, because your provider wants to ensure that as a team you're able to meet your goals, and they could be different from different people. But certainly if you have things that you want to do that you can't do, I think you need to share that with your oncologist so that you guys can work together to try to achieve those things. And on that line, if there's special events coming up, if there's a wedding coming up, if there's a trip you want to take, if there's a graduation you want to be well for, I think those are very important things to share with your oncologist, because they're really meaningful milestones in people's lives. And we want to work together to ensure that we can meet those. Things like adherence to the medications as much as possible is important. Remembering to take the medications and to work together. I think collecting information, sometimes for some people, it really works to have a diary and to write down their symptoms and to write down what they're feeling, so that when it comes time to see their oncologist, they have that data and they can sort of look back and reflect on it together. I think nutrition is important, and sometimes we have patients that are struggling with nutrition, and we want to working together with a dietitian and nutritional support to try to make sure that we're able to optimize nutrition. And I think one of the things I would say that's probably underemphasized sometimes is this is a stressful process, and I expect it to be a stressful process. And so ensuring that we take care of our mental well-being is very important. And most cancer centers will be able to refer you to a psychologist or to a team of people, and it may even be peer support, a patient support group. But I think taking care of your mental well-being as well as your physical well-being is very important. A lot of patients ask me about exercise, and we certainly encourage exercise, but to a point of where your body tells you. I think listening to your body is very important. And my advice would be to stay active, but not push yourself too hard such that you get fatigued or it sort of sets you back. You really want to maintain a good physical exercise to the point where your body tells you that's good. I'm happy there.
I start every morning with just this whole slew of thank yous. I'm thankful for my ability to access incredible care. I'm thank you for my super sweet husband. I'm thank you for my supportive family that I call Team Positive. And that's just the beginning. I'm so thankful for so many things, and I try and throw them out there every day because remaining grateful is something that keeps my head on straight.
Movement is probably one of the hardest things when you're undergoing treatment. You don't want to move. You just want to lay in bed because you're nauseated. You're low in energy. There may be many other things that you're experiencing just because there's other underlying health issues that you may be experiencing that other patients may not be. So being able to move gives me that ability that I am grateful to do that. At the same time, it alleviates any symptoms.
I focus probably more on my mental health than I do on any treatment. So I get lanreotide every 28 days. But outside of that, I meditate, I try to do yoga, I try to exercise, I walk outside as much as I can, I intermittent fast, I take some supplements. I do a lot of things to really focus on my head, honestly, just my headspace and how I'm feeling, that I feel have really helped me. I volunteer a ton and I'm unemployed, but I keep myself busy because the more I engage my brain, the better I feel physically.
On the days where I'm feeling great, where I just like I have a shot coming up or, I have a scan coming up, I just try to say, okay, that's for that day. Let me just table that aside and then focus on, making what I have now and making today really count and really, just doing little things that make it go well. And then once that day comes for my lanreotide shot or a scan, then that's the cancer day for me, but really just compartmentalizing the days.
As a caregiver, I make sure to take care of myself as well in between all the scans and appointments that I go to for my mom, because if I'm not taking care of myself, there's no way I could take care of my mother.
Thanks again to our Thrivers for their perspectives. As we think about hope and what it means to all of us, we want to look into the future. What does hope look like for NET research, treatment, and Thrivership? Hear what our speakers say about that, and then join us for our live question and answer segment. You can submit your questions at slido.com. What gives me hope is seeing the growth of the NET research community around the world and knowing that these scientists are working every day to discover the mysteries behind neuroendocrine cancer and to develop new treatments. So I think the future is bright and there will be many more options for neuroendocrine cancer patients.
I'm extremely hopeful and optimistic. For NETs, we've already seen significant strides in drug development. In front of my eyes, several pivotal randomized phase 3 studies have read out and has really transformed how we manage neuroendocrine tumor patients. And several more are in the pipeline, which will take our field to the next level. For example, PRRT, the novel forms of PRRT, the alpha PRRT are very exciting. Combination PRRT with radiation sensitizers are extremely promising. So for NET space, very, very excited how things have really evolved with everybody's support, especially the patient advocacy groups, the government, the policymakers, and industry. I do feel that we do need to catch up when it comes to NECs. Very tough disease, the outcomes are very dismal. However, I do feel optimistic about the field. The recent approval of DLL3 BiTE antibody was fantastic. I personally treated some of the early first-in-human patients on that. I've seen firsthand, and patients who benefit from that drug do experience long, durable responses. And that's the direction we need to head in, find novel, promising targets and drugs which don't only improve median PFS by a month or two, but significantly improves the outcomes. Similarly, radiopharmaceuticals or application of radiopharmaceuticals in NECs are very exciting, and other target therapies like PARP inhibitor IO combination. So again, a lot of potential opportunities for drug development in NEC space.
What really gives me hope is the community for neuroendocrine tumors. So the patient community, the support organizations like NETRF, it's a really close-knit group, and there's a lot of great things that these communities can help us, through advocacy, through outreach, through education, to spread the word about neuroendocrine tumors, to garner funding for research, to help us in our research to accomplish what we need to do. And in our research, we're very excited to, continue to develop better treatments for these neuroendocrine tumors. And no doubt is thanks to all the advocacy and support from our foundations.
What gives me hope for research at NETRF is our collaborative group of researchers who are in the lab every day working to learn more about this disease. We're very hopeful for different areas of research, such as early detection, improved radioligand therapy, as well as immunotherapies.
Probably the most reassuring thing about this field is the incredible community that we enjoy between the researchers, the clinicians, the patients. I think the genuine collaborative spirit that everyone has really gives me tremendous hope that we're just going to continue to keep pushing forward, even when things are difficult or vexing or confusing, and we're going to continue to invest our time and energy and make progress together.
The increasing number of researchers and clinicians who are focused on NETs is giving me a lot of hope that we're going to make progress much more quickly and with more informed movement in what we study.
My hope is that there is much more awareness. There are much more providers that are becoming interested in this disease or seeing more of this disease. So that gives me comfort that patients will have providers with more knowledge. I was just discussing with oncologists recently that she was like, gosh, I'm seeing so many NET patients. I was like, you know what? Why don't you come to the NETs meeting in October? And she's like, I might do it. So I'm happy that there's more healthcare providers that are getting involved. And then on the scientific front, there are so many new strategies and trials, and the community is really focusing on develop more treatments. I think theranostics and PRRT, and either with treatment or with combinations, is really going to make our patients live longer and with quality of life. And hopefully we will continue to develop strategies for patients that do not qualify for whatever reason for PRRT, and we need other drugs to help the patients. The future is bright for neuroendocrine cancer care.
What really gives me hope is that there is a lot of drug development at the moment. There are a lot of companies developing new kinds of drugs, and I think we need to try to see if these are effective in our patient population. And for that, we need a lot of new knowledge, and this knowledge is being generated. There are big studies coming. There are big studies being published at the moment that show how the molecular landscape of these tumors is separated, and I think this knowledge, compared to all the new drugs that are coming, might enable a more effective treatment in the future.
I think what gives me hope is the fact that it seems to me that there are tremendous advancements in all avenues of therapy for cancer care, and specifically for neuroendocrine cancer. I think, at least speaking for myself, I think we've talked about histotripsy, but there's a lot of other innovative therapies that are coming out, including robotics, direct tumor injections, a lot of other things that are on the horizon. And it just seems like each year there's more and more opportunities and options for our patients.
What gives me hope, first of all, is our patients. I think patients are really the backbone of all we do, especially when it comes to clinical care and research care. Seeing patients doing better and better over the years, living longer and longer, having a better quality of life than they even had 10 years ago, I think that really gives me hope that we will be able to cure this disease. The other thing that gives me hope is to see that patients and their families and their friends seek out neuroendocrine tumor specialists, are part of support groups, are part of online groups, and really support each other. I think that being diagnosed with neuroendocrine tumor is a journey, and you can have the best clinicians and the best therapies, but ultimately patients have to go through this journey with their friends and their family, and also with people that perhaps through these support groups, through these online groups, don't know them, but still share their experience and their recommendations. And I think that that's getting better and better. And I think that it really helps patients. And therefore, I would assume that this will continue to develop further in the future and help our patients even more.
I've been doing this now for 20 years, and the expansion of genetics and the role of treatment options for patients has exploded exponentially. And that part makes me the most excited, because we can offer patients now treatment options that extend their life by 10 years. So you're no longer dying of your cancer, you're living with your cancer, and that's okay. Similar to any other disease type like diabetes.
One of the things that gives me hope as someone who works with people living with NETs is seeing the amount of love and care and dedication that the professional NET specialist community has. You have a lot of people working very hard for you.
From my personal experience, what I will say has given me hope is just seeing the advancements. When I first started working with patients with a specific diagnosis, I'll be very honest, I didn't really know much, and I don't think we even had a surgeon on staff yet. So just seeing the fact that our program has grown to the point where we now have, oncologists that specialize in this, medical oncologists and our surgical oncologist, and the fact that I'm seeing all of these additional resources and webinars really does give me hope, because I'm seeing this information being more readily available for our patients, who I can think back about 7 years ago when I started working with this patient population. I mean, there was really nothing available. And if it was very vague. Whereas now, when I, was preparing for this and I was looking online, I see so much more information that, patients can refer to, which is hopeful.
I think there's a lot of things that give me hope. One is we're finally starting to recognize this disease. Before, when we started our clinic here, for example, many of my colleagues would say, "What is that again? How many patients have that? Do you even have enough people for a clinic?" And certainly now there's recognition that this is a common disease and people are living with it day in and day out. I think the emphasis on quality of life and patient well-being as part of the treatment journey is something that is a very positive step forward. Like I said, we're understanding not only about helping patients live longer, but help them live better. And we're including that in the research and the work we do. We're developing steps towards personalizing treatment. So understanding that not all neuroendocrine patients are the same, and they may have personal preferences, but also their diseases are different and their treatments may need to be tailored to that person. And we're making big steps in getting towards that area of personalized medicine. And then, of course, the research of the new treatments that are coming aboard. We're having more and more new treatments. We're understanding sequencing. We're understanding how to combine the treatments to not only improve outcomes, but to make people's life better.
What gives me hope about NETs is you can actually see quite tangibly progress. One of the most amazing slides I see at some of these conferences is looking at the new treatments that have been approved over time. So typically the x-axis, if you will, is years. And then you can see that it's accelerating. So there was probably a good decade or two there where very little happened in the net world. And then there's been an explosion of advances. And sometimes I sort of talk about 2009 as the year from which henceforth everything has changed. So in 2009, we really sort of embraced long-acting octreotide or sandostatin LAR. 2014, we embraced lanreotide or somatulin. 2017, 2018, we started getting into drugs like Zermello that help with carcinoid syndrome. And then the FDA approval of Lutathera was a complete game changer. So my point is, after a very fallow period where NETs were viewed as, quote, too rare to study, we now understand that they are hugely prevalent. And most importantly, there's things that we can do, things that matter, things that extend lives and improve quality of life. And I think seeing that real progress, and you do have to zoom out a little bit sometimes to see it, that gives me hope.
I think in 20 years, we have many more treatments, but it's not enough. And I think that's the promise of the future, to see the growth of the NET research community and know that they are working so hard every day to develop even more treatments and more options for patients.
Seismic changes in how we manage neuroendocrine tumors over the last 20 years. From no treatment to maybe one treatment called somatostatin analog, to now multitude of treatments with PRRT, targeted therapies with TKIs, mTOR inhibitors, and several in the pipeline now with newer forms of immunotherapies, cellular therapies. It is just a roller coaster ride, and just super happy for the field, for the patients, for the caregivers, and my colleagues in the community. It's just fantastic, fantastic growth. This really materialized because of our better understanding of neuroendocrine cancers. I think a big role in the drug development space happened from understanding the burden of disease, diagnosing neuroendocrine tumor appropriately, pathological classification, so we understood what we are dealing. It's not all lumped into carcinoid disease, which are considered benign. So we've moved away largely from a lot of those myths. We now have a much better understanding about neuroendocrine tumors, which are the aggressive varieties, which are not so aggressive varieties, and how different grades plays into the prognosis, so we can tailor treatments accordingly. So that by far has been the biggest thing, in my opinion, over 20 years, better understanding of the disease period that has led to better treatment options for our patients.
We've seen a lot of changes in NET treatments. In I think 20 years ago, the only treatment available was surgical debulking for symptomatic patients, and then came the somatostatin analogs, then came PRT and all these targeted therapies. So the treatment landscape has gotten a lot busier and for the better for neuroendocrine tumors. And we have more exciting things at the horizon, next generation PRT, next generation immunotherapy approaches, including CAR-T or cellular therapy. So lots to look forward to.
The changes I've seen in treatment over the last 20 years is that we went from having no approved therapies to having multiple approved therapies here in the US for neuroendocrine tumors.
I think there's been tremendous progress in the last 20 years. The fundamental difference from 20 years ago is really the introduction of randomized data and I think evidence-based medicine, which has, I think, totally transformed the landscape of what we do. I mean, almost everything we use today, we didn't have 20 years ago. Certainly not in the States, whether that's radioligands or the targeted therapies. It's really been quite amazing to sort of look back and think about just how much was different 20 years ago.
We have more targeted therapies that are beneficial to these patients. So we've seen improvements in peptide receptor radiotherapy or PRT, and we have had targeted treatments, whether it's against activated pathways that are specific in certain tumor types, like everolimus targeting the mTOR pathway, or sunitinib that prevents the tumors from becoming more vascularized. And so I think we've been able to better tailor the right drugs to these patients based on what we've learned about their biology. And that's improved dramatically over the last 20 years.
When I sit with my patients, especially when they were early diagnosed, but they unfortunately already are diagnosed with metastatic disease, I said, this is the roadmap of the treatments that we have for you. And I count like 5 treatments or more. And when, 20 years ago, we didn't have all this. We have somatostatin analogs pretty much, right? So as the drug development for this disease has grown so much, and it's fun to go over with patients and draw in the whiteboard for them. These are all the treatments. This is the benefits in the literature has shown. Obviously, everyone is different. And then, guess what? By the time that we exhausted all these options, I am sure there's going to be more options. So let's just keep you healthy and around and until the next best thing comes.
I have some experience over the past few years in the treatment of these patients. And of course, I am into the literature of these cancers. The biggest changes, I think, which are coming now is the knowledge that we are getting from the molecular subtyping of these tumors. So it's not only typical and atypical, there's a whole spectrum behind these separations. And I think these insights will really give the field in the next few years a new edge, a new incentive to do more research.
We have seen vast changes in interventional radiology. It's a very young specialty. It's essentially was founded in the late 60s. 20 years ago, we didn't even have catheters that we could put into the arteries of the liver. And now we have sub-millimeter catheters that we can get out into 1 or 2 millimeter vessels that feed tumors. So we have seen exponential changes in our field, and that's really translated to super targeted therapies that we have for our patients. And then there's always new technologies that are coming out that are less invasive, and as we've seen with histotripsy, that are actually non-invasive as well.
So over the past 20 years, we've made huge progress in terms of systemic therapies, particularly the development of theragnostics, so both for diagnoses as well as for therapy of metastatic neuroendocrine tumors. Things have pretty dramatically changed. I would say that the theragnostics part has been, in my opinion, the most exciting part, with also the most potential for the future. But there have been other things like targeted therapy, everolimus, sunitinib, now recently cabozantinib. So as we understand the molecular composition of these neuroendocrine tumors, as we understand what drives them, we are able to design new therapies. And that's what's been done over the last 20 years, and I think will continue to happen in the future.
When I first started, most of the talk when it came to hereditary forms of cancer were primarily around breast and ovarian cancer. And so it's only within the last 10 years that people are like, well, wait a minute, take a look at these other syndromes that have always existed but haven't been on other people's radar. So that's the part that makes me excited about that field, is that we are now seeing neuroendocrine tumors, more people be aware that they even exist. And I think a lot of that is around these hereditary forms that are putting it on everybody's radar.
I've been working with the NET community for 2 years, but I know that there has been a whole lot of changes in the last 20 years. And this gives me great hope, because I know that once there is momentum with treatments and research, that things continue to progress, and then there becomes more treatments and continues to have more research. So there's a lot of great things happening, and the past 20 years are a big part of the story.
The biggest change that I've noticed would honestly be the treatments and the multidisciplinary care approach that has started to develop over the last several years. At least at U Chicago Medicine, I've seen the biggest change, because we've gone from not having this specialty to now having an entire group kind of dedicated to, this patient population, which as a result has included various different kinds of treatments by different kinds of providers, and it's overall helped improve the outcomes from what I've seen early in my career versus now.
What has really been exciting has been the number of new treatments that we've had developed. At 20 years ago, we really had one treatment and, somatostatin analogs. And now we have a range of different treatments that have been developed and understanding. So the research of development of new treatments. And then we add on to that now radioligand therapy, a whole different way of treating cancer, which is going to be a big part of treating all types of cancer in the future. And for us to be able to start this journey in neuroendocrine cancers is very exciting. So I think the number of new treatments and the number of new ways we have of treating neuroendocrine cancer has really been exploded in the last 20 years.
Yeah, it's pretty remarkable. So, my dad died in 1994, and I sometimes wish I could get in a time machine and go back and show him modern medicine that he might benefit from it. So the two things that are closely linked that have gotten better are diagnostics and treatments. Even when I was first diagnosed in 2009, some of the scans that we had then, I'm thinking specifically of the Octrio scan, if anyone listening has ever had that. The Octrio scan, which more technically was called a 111 indium somatostatin receptor scintigraphy, again, that's why we call it the Octrio scan. It gave us a map of the body that frankly looked kind of like a snowstorm. It was this really blurry, high-level map, and it didn't give you a whole lot of anatomic detail. And now we have things like dotatate PET scans, whether performed with gallium-68 or copper-64. It's basically the difference between going from old TV, sort of the massive box with sort of a grainy picture, to modern flat screen that can do high def. And the reason that matters is the more that you can see, usually the more you can treat. So if something lights up on one of these modern PET scans, it means that we can target it either with somatostatin analogs and or with PRRT. So I think this whole field of theranostics, the notion of being able to see more and then treat what you can see, I think that's what's changed the most.
My hope is that in 5 years, first of all, we are diagnosing and detecting the disease much earlier, so we have more options for patients, and that we have many new treatments that today really are just someone's innovative idea, and that we're able to pursue those ideas into the clinic.
Clinical oncology and research is probably the most dynamic field in all of the medicine. The most number of trials, most number of research, most number of research dollars being spent. It will be difficult to predict how next 5 years will pan out. Things that I'm personally very excited about is the role of theranostics and growing role of theranostics in management of neuroendocrine tumors. So in about 5 years, I foresee not one, but several of theranostics drugs will enter the field, which will make it a little bit challenging for us as providers, but it'll be better for overall field because we have more tools in our toolkit to manage this cancer. So we will see alpha PRT, we will see novel types of beta PRTs, combination of PRT with other agents. So I think that's where in the next 5 years I see the most promise, the advent and the growing role of theranostics in management of NETs.
Several of the ongoing trials will help us answer how we best kind of sequence or combine the available treatments. We'll probably find out about what are better predicted biomarkers in terms of looking at tumor genomic data and then predicting which particular treatment is a better fit for the patient. And of course, we'll probably have newer versions of the existing therapies such as PRT or immunotherapy and etc.
I hope that in 5 years, neuroendocrine cancer treatments will have improved to the point where we can individualize treatments for patients, that we're able to incorporate molecular and genetic data about a patient and their tumor into their treatment plans, and that we have a better understanding of how to sequence treatments so that every patient gets the most optimal treatment plan for them.
Yeah, I think in 5 years, I think we'll largely be seeing the impacts of studies that are ongoing today. I think there's a lot of novel radioligands at the moment, and I suspect that as those sort of complete their development cycles, we're going to see dramatic changes in the arsenal of radioligands and standard therapy.
Over the next 5 years, I really hope that we are going to give the patients some new options that will in some way improve anti-tumor immunity. What we hope to do is leverage that immune system to help fight off the cancer. And I think not only the research that my group is doing, but many other groups, we're trying to figure out how to harness that immune system and use it to better kill off the tumor cells. That is one of the best things that we can do because it would provide a sustained anti-tumor response or durable response that we hope could last a lifetime and really just change the outcomes for these patients to something wonderful.
So I think for the starters, I'm really hopeful that we're going to be seeing much more of retreatments with PRT and PRT with combinations. And I think that hopefully we'll start having a hint if CAR T cell or cell therapy strategies work for neuroendocrine cancers. I know that there are some trials that are just started or about to get activated, and gosh, if that works, it will be amazing. So there is a lot of hope in the emerging treatments. It's becoming a very complex disease to treat because all our options are amazing. And, I already try to do and understand as much of theranostics as I can. And if the cell therapy pick up speed for neuroendocrine cancers, then I'll have to go back and learn more about cell therapies. That's something that I don't use very often for my other cancers that I treat even. So yeah, it's fun with the new treatments that we develop. We as scientists and physicians, we also have to go back to school and learn more about this. So it's a fun time to be a neuroendocrine cancer doc.
What I envision, what we're currently trying to set up, is that we have a multi-platform study where we can evaluate all these different tumors based on the molecular subtypes. And for each molecular subtype, we try to prescribe a different treatment. This will be very difficult to do because of the low incidence of this disease and because these type of studies are very expensive to do. But if we are able to provide a molecular subtype treatment, then I really think we can improve the efficacy of our drugs, decrease the toxicity, maybe even for some patients where you know that it doesn't work. So that is my vision for the future, and I hope we see that happening in the next 5 years, which is a personalized treatment.
I'm really excited to see what the next 5 years brings us. I believe that we will continue to develop new therapies for our patients that will continue, at least on the interventional radiology side, be less invasive, allow patients to sort of return back to living their lives with less downtime. And I think, again, a big focus, at least in our specialty, but also in cancer care in general, is quality of life. And so just maintaining a high quality of life.
I think in 5 years from now, you will see a whole new set of radiotheragnostics. So what's very exciting for radionuclide therapy is that we've been using beta-emitting particles in Lutathera, but there are now new particles that we're studying, like alpha particle. They travel less, but they have higher energy, so the potential to destroy more. So I think that alpha therapy is an exciting new concept. But on the other hand, I also think that PRT as it is right now is far from having achieved its maximum potential. I think it is important that we continue to focus on understanding why these therapies work, understanding why certain patients respond better than others, understand whether we can combine radioligand therapies with additional drugs to improve their efficacy. I think this is what you're going to see over the next 5 years. In addition to, and this comes back to my talk a little bit, understanding treatment sequencing. I think that really understanding what treatment is best at a certain time in a patient's journey is something that more and more groups are looking into. And I think that as we collect more data and collect more information on how our patients respond to certain therapies, we will be able to tell you in 5 years, what the next best treatment option is, rather than just kind of shoot in the dark and be like, well, we'll try this therapy, and then if it doesn't work, we'll try something else. So I think that those two things, theragnostics and specifically radioligand therapy, as well as treatment sequencing, are the two things that you will see that will drastically improve over the next 5 years.
We're going to find out more and more about other disease types associated with neuroendocrine tumors. SDHA and SDHB, CD, all of those are all relatively new genes that we've just recently discovered. And I think that now that we're doing more panel testing, we're going to be able to find reduced penetrance with some of these conditions. So take, for example, VHL. They used to think that there was 100% penetrance, meaning 100% chance you were going to get some form of cancer associated with VHL. And now that we're doing panel testing, we're finding more and more unaffected people that perhaps maybe this penetrance is not as high as we originally thought.
Neuroendocrine treatments have been changing rapidly fast. There's a lot of excitement, and there's a lot of attention around radiopharmaceuticals and PRRT. There's a lot of things going on in this space, and I think it's an exciting time. And I actually believe that in 5 years, we're going to see a lot of changes and a lot of good things happening and a lot of choices for people.
I think in the next 5 years and beyond, what we're going to see is more personalized treatment. We are going to be able to tailor the treatment with the different treatment options we have now, both in terms of what's the right treatment for the patient and for the disease they have, and also what's the right sequencing and what's the right timing. And I think being able to offer individualized treatment plans is going to be a very exciting part of the future of neuroendocrine cancer.
I think they're going to get more targeted. What I mean by that is, chemo gets a pretty bad rap, and deservedly so. It tends to cause a lot of indiscriminate toxicity, meaning that most chemo kills whatever is growing in the body, good or bad. So patients tend to lose their hair, they can get mouth sores, they can get horrible diarrhea if they slough their gut. But what we're really after, of course, is direct impact on the tumors. So I think the way I see the arc of history bending in oncology and in NETs as well is to make it more specific so that a given treatment is affecting the tumor and hopefully leaving the patient alone. And PRT is pretty good at doing that. Remember that, this whole notion of targeted therapy means that when you give someone PRT, the radiation dose is largely, not quite exclusively, but largely being delivered like a smart missile to the tumors, and ideally the tumors alone. And we're getting better and better at that. You have to delve into nuclear physics a bit, but as we get into the alpha emitters, isotopes like actinium, for instance, they emit such a tiny amount of radiation, or at least over a tiny distance, that you should really be dropping that payload on the tumor and leaving the person alone. The reason that matters is less side effects for the person and less long-term risks, like less risk of, for instance, bone marrow damage, more protection of the kidneys. So I think that's where we're heading, is getting more precise, making ourselves, the oncologists, less of a blunt instrument.
Welcome everybody to our Q&A. We hope that you've had a nice day and that you enjoyed all the talk that were provided. I'm Dr. Xavier Keutgen. I'm one of the co-chairs of this NETRF symposium. And with me today, I have Dr. Aman Chauhan from the University of Miami, Dr. Heloisa Soares from the University of Utah, and then Dr. Andy Liao from the University of Chicago. Dr. Greene is also with us today, and she will answer any questions related to neuroendocrine research and specifically NETRF research. So the way this is going to work is we selected about 10 questions that I'm going to ask. We will hopefully get into a nice discussion. So let's get this off here right away. So the first question that was asked by one of our patients, which is perhaps the questions for Dr. Chauhan. Are there any clinical trials that are currently being conducted to prevent recurrence of neuroendocrine tumors? And I'm assuming that's after surgery.
Actually, I have our star investigator here with me on the panel, Dr. Heloisa Soares. I'd like to highlight one of her SWOG studies. It's actually one of the first of its kind studies, which is looking at trying to reduce the risk of relapse in pancreatic neuroendocrine tumor patients. These are the patients who had a resectable pancreatic neuroendocrine tumor, but at a higher risk of recurrence because of certain factors, could be grade, symptoms, tumor size, etc. And what Dr. Soares and colleagues are doing on the trial is to give a trial of 4 months of chemotherapy, which we know is very effective in pancreatic neuroendocrine tumors, but in the adjuvant setting after surgery to see if it can minimize the risk of recurrence. So it's a randomized study. So some patients will just get standard of care observation, and other would get the chemotherapy with CAPE-10. So again, hats off to Dr. Soares for leading this fantastic study, which hopefully will tell us whether these strategies or adding chemotherapy after surgery may benefit. Now, if we see positive signals in pancreas, I think this is a trend that maybe we should investigate in lung NETs and other NETs where we kind of treat them with early stage stage with surgery and try to then add adjuvant therapy to prevent the relapse. But yes, that would be probably the premier study right now.
Thank you very much. Okay, so the next question will go to Dr. Soares. So the question is, can you please address the treatment option for grade 3 well-differentiated versus grade 3 non-differentiated? So I'm assuming in this case, poorly differentiated carcinoma. How do they differ, and how does the treatment differ? Obviously, that's a whole talk, but just in a few minutes.
Thank you. You know what I was probably going to start saying. There's so much nuances to the question, but I think the first step is we treat very clearly in a very different way the poorly differentiated grade 3s versus the well-differentiated grade 3s. The poorly differentiated grade 3s, we typically start with IV cytotoxic chemotherapy. There's actually an ongoing trial also with the cooperative groups sponsored by the NCI to look into see if, in addition to a platinum plus etoposide, which is a traditional IV chemotherapies that we use, if adding immunotherapy to that by extrapolation, which was seen in the small cell lung cancer data, if the immunotherapy will contribute to that. That's a study that's ongoing. And then following that, there's other studies and other IV cytotoxic chemotherapies that can be used, but also the role of dual drugs with immunotherapy. And Dr. Schaumann has been very critical in developing a lot of the treatments for the poorly differentiated neuroendocrine carcinomas. And when we talk about the well-differentiated ones that are grade 3, is really trying to understand the biology of the well-differentiated grade 3. If they light up well in the dotatate scans and they tend to have a more indolent approach, you would treat as any of the well-differentiated grades 1s and 2s. But there are some bad players that might behave a little bit more aggressive that you might end up having to use more aggressive chemotherapies in the beginning. Also now, thanks to the NETRF study, we know that we can consider PRRT for patients that have a well-differentiated grade 3 tumors that light up on the dotatate scan and have a Ki-67 less than 55%. And Aman, do you want to highlight any of your studies for the poorly diff? You have so much going on in that area.
It's finally heating up, so I agree. Thank you, Dr. Soares. I think that some of the promising early phase studies are targeting DLL3. You might have heard some news about it. We just had an FDA-approved drug targeting DLL3 through an immune mechanism called BiTE, or bispecific T-cell engagers, for small cell lung cancer, which is a sort of a sister cancer to a lot of our extrathoracic high-grade poorly differentiated neuroendocrine carcinoma. So there are a couple of clinical trials by BI called Darien-5 and several others, so Darien series of trials that we have opened here, as well as several other sites in the US and outside that are looking into this. There are trials. We personally at University of Miami are investigating a bioengineered virus, oncolytic virus called Seneca Valley virus, which seems to be attracted towards neuroendocrine cancer, especially the higher grade kind. And we have some of the animal data looks very promising, and we are combining it with the traditional immunotherapies. Earlier, Dr. Halperin had a great talk about some of the challenges with our traditional immunotherapies in neuroendocrine cancers. We are trying to overcome those challenges and trying to make these supposedly cold tumor hot, make them immunogenic so that they can respond. So these combination therapies, these are underway as well. And then there are certain trials looking at immunotherapies plus some TKIs with the same sort of rationale to really rev these tumors' immune system to respond. So thank you, Dr. Soares, for highlighting. It's a critical unmet need, and hopefully we can get a breakthrough soon.
Thank you. So Dr. Liao, these next two questions are for you. So the first one is, before my lung surgery, bronchoscopy showed a Ki-67 of 10%, and then the surgery showed Ki-67 of 4%. Is that possible? So I'm assuming that goes to tumor heterogeneity. And then the second one is, after PRRT treatment with Lutathera and long-acting octreotide, do you continue the long-acting octreotide indefinitely? And is octreotide better than lanreotide?
Yeah, it's a great question. So the first question, having two slightly different pathology reports from the initial biopsy and then at the time of surgery, that's certainly possible, and we see it all the time. And that goes to to what Dr. Keutgen was saying about tumor heterogeneity. So if you have, this is your tumor, it may be made up of billions of cells, and if you stick a needle in it, 2 different places, you may get slightly different clones of cells, and they may read slightly different. And the other thing is, when we have the surgical specimen, there's more cells for staining for the pathologist to look at. So we definitely can sometimes see minor variations like this from 2 different biopsy specimens. And then the second question is also a good one. Do we continue the somatostatin analog after PRRT treatment? Well, the NETRF study, which was the study that PRRT approval was based on, they did continue the somatostatin analog. And so in our practice, we tend to, especially if the patients have carcinoid syndrome, if we're giving the somatostatin analog to control their hormonal secretion symptoms and things like that. But, what about a patient who had previously, their tumor had progressed on somatostatin analog? Is there value to continue on? I think that's a question that remains to be answered in future studies.
Great. And is lanreotide better than octreotide?
They're 2 different brands. They both work the same way. They're both somatostatin analogs, and they're delivered differently. One is an intramuscular injection, the other one is a deep sub-Q. We consider them to be clinically equivalent. Of course, there's no head-to-head comparison study. Patients may have anecdotal experience of liking one versus the other. We know they definitely have different pharmacokinetics. So after the shot is delivered, how it hangs out in your body is a little bit different.
Great. Dr. Sean, as a follow-up for the heterogeneity question, is there any particular way that you deal with heterogeneity within the same surgical sample? Let's say, somebody goes to debulking and, or even within the same biopsy sample, and you have different types of Ki-67s. Do you treat the highest, the lowest? Do you take the average? How does that work?
Thank you for that question. It's unfortunately one of rather common scenario in our area, discrepancy of Ki-67 and tissue-related issues. And even with the same set of slides, there is even data to suggest that 2 different pathologists might have different interpretations. One of the pathologists actually told me it's like counting the cows in a herd, right? So it's not a perfect science. However, we recommend that pathology be reviewed at a high volume center where the pathologist is in tune with seeing these rare cancers. Now, when we see these discordance between low Ki-67 and high Ki-67 or low mitotic index or high mitotic in tumor, by definition, we have to grade the tumor based on the highest grade. That will define the biology of the cancer in majority of cases. So if it's a Ki-67 12% at certain area and 1% in a certain area, this will be a grade 2 neuroendocrine tumor. And I would be compelled to watch this patient more closely because I expect this might be a more faster growing tumor. So those are some of the clues from pathology. However, in real time, we can also do molecular imaging to kind of help us understand the true biology. So if we are dealing with a metastatic disease, so we can do DOTA-8 PET scan and look at the somatostatin receptor expression, which majority of our GAPNet patients will have very SSTR-avid disease. However, if we are dealing with a grade 3 or higher grade 3 well-defined NET, as the grade increases, sometimes the receptor density comes down and they become more dedifferentiated. So we might see certain areas which are not lighting up as avidly on a DOTA-8 PET, which will trigger me to do an FDG PET, which is a common PET scan that we do in common cancers. And if it lights up, that suggests it's a more aggressive biology. These tumors are taking up more of the radio-labeled glucose. At the end, the ultimate decision is on the biopsy. So if my suspicion is high that there is discordance and there's a heterogeneous disease, it's not all same disease, and there are areas of high-risk disease with higher grade, we end up doing a biopsy to eventually confirm, because at the end of the day, the biopsy trumps everything. It's the final word.
Thank you for this clarification. So the next question is for me, so everybody can just lay back and relax. Is the preferred treatment for a gastrointestinal neuroendocrine tumor still a hemicolectomy? I had heard that this may no longer be true if a tumor is able to be fully removed. So that's a great question. And as a matter of fact, I've seen a similar case not too long ago. So a hemicolectomy really only needs to be done if the small bowel neuroendocrine tumor is in a very distal part of the small bowel where the blood supply to the distal part of the small bowel is actually also the same blood supply to the right colon. And when we remove a neuroendocrine tumor, we would want to remove those lymph nodes, and those lymph nodes run around the blood supply. So it's really important to understand how these tumors drain their lymphatic channels and where the lymph nodes can be found. So again, if it's in the distal part of the small bowel, you're not going to get along trying to just remove the distal part, because you'll devascularize some part of the bowel, which is in this case the right colon, that then will have to be removed as well. So distal part of the small bowel, always get a right hemicolectomy. If it's anywhere else in the small bowel, and there certainly can be anywhere in the small bowel, although the most common location is the distal part of the small bowel, then no, you don't have to do a right hemicolectomy. You can actually just do what's called a small bowel resection. So you just remove the segment of bowel with the lymph nodes and the mesentery to be able to harvest as many lymph nodes as possible. One of the things that Andy and I have seen, I think last year, was a patient that presented to us where it was proposed to her that the endoscopist, through a colonoscopy, would try to carve out a tumor in the distal small bowel. So that's a bad idea. Why? Because these tumors tend to be in the submucosa, and so the risk of perforation is quite high, and also you're not going to clear out those lymph nodes. So endoscopic resection of neuroendocrine tumors can be done. They can be done for rectal neuroendocrine tumors that are small. They can be done for gastric neuroendocrine tumors that are small. They can be done for duodenal neuroendocrine tumors that are small. That's not a good option for small bowel neuroendocrine tumors, just because of generally the locations. These tumors tend to be a lot deeper within the layering of the bowel, and the risk of a perforation is very high. So that's my answer to the question. Unless there are any other comments, I'll move forward to the next one.
I wonder if the person that is asking the question is also thinking about the appendix. Can you comment on that?
Yeah, that's another great question. So appendiceal neuroendocrine tumors are very often found incidentally, right? We often don't know that patients have these tumors, and when they develop acute appendicitis, the appendix comes out, and then they have essentially an appendiceal neuroendocrine tumor on the final pathology. Now, is the right hemicolectomy necessary for an appendiceal neuroendocrine tumor? It depends. It depends on a lot of things. And even there's still controversy. We had a great NANETS talk, if you remember, all three of you, last fall in Montreal. But essentially, if appendiceal neuroendocrine tumors are low grade, which they almost always are, if they are in the distal tip or away from the base of the appendix, and if they are less than 2 centimeters, generally speaking, they're considered not invasive enough to require any additional surgery. So generally, an appendectomy is more than enough. There are some studies that suggest that for T3 tumors, or tumors that invade into the mesoappendix or through the serosa up to 3 millimeters, that those are at higher risk to develop lymph node metastases, and therefore right hemicolectomy should be done. We're pretty conservative at the University of Chicago generally, and this is only one study that had really shown that the risk of a lymph node metastasis is higher. So generally, if there are not any other features, if on the CT scan or on a dotatate PET, which we can also do sometimes after these cases, there is no suspicious lymphadenopathy, we generally, even in those cases, will tend to surveil. How long you surveil is a whole nother question for debate. And again, there was an actual debate at NANETS about that. Do we just do 1 year and then that's it? Or should we follow up for 10 years? That's up for grabs. And I think we need more studies to define that. Our practice at the University of Chicago, and certainly I'm curious to see how they do it at the University of Utah and University of Miami, is that if it's a low-grade tumor with a low risk of recurrence, we generally tend to actually repeat a scan a year later. And if nothing shows up, and it's really in the low risk category, we tend to then stop following them long term. The other question is the role of dotatate PET, right? Should we really do a dotatate PET on everybody? Should we do it a year later or just a regular CT scan? Again, a lot of different things that are still up for grabs and need to be questioned. Okay, let's move on to the next one. So, do we understand if and how neuroendocrine tumors or neuroendocrine carcinomas can be passed on to our children? And is there any testing that we need to do or that can assess the risk of developing neuroendocrine tumors or even symptoms?
So for the majority of the neuroendocrine tumors, there is really no genetic association to the point that you were born with a germline mutation that makes you predisposed. So for most of the patients, no, we don't know, and there's no risk that your family or your children will have that. There is about 10% of patients that will have a germline mutation associated. Typically in the family, there will be more family members with the particular gene. M1 is one, VHL is another one, and there are many. And then if there is a suspicious that by history or any other features that it could be actually a tumor that was generated because of germline mutation, there is blood work that can be done. And if it's positive, then there is a significant counseling with genetic counselors. They will be advised to have the family members that are first-degree family members to be tested as well. For most of the patients with GI neuroendocrine tumors, there's very little association. For paragangliomas and pheochromocytomas, by default, they all should be tested because the chances of having a mutation is a little bit higher. But for the lung and for GI, well differentiated is the minority of the patients.
Thank you. Next question is for Dr. Liao. After my second PRT treatment in concordance with long-acting octreotide, my scans showed more tumors and growth. The question is that a common scenario? And I would add a couple more questions to that is, how do we routinely scan after 2 cycles after PRT? And if there is progression that's believed to be true progression, should we continue or should we stop at that point and switch gears?
That is a great question. In our practice, we do scan in the halfway point, so after 2 of the 4 cycles. And really, it's only because every now and then we see patients whose tumors are growing so rapidly that they don't respond at all to PRT. We want to identify those patients to take them off treatment that's not working. But to answer the original question, it just depends on how much more growth there is. Is it kind of mild growth or is significant growth? We know that PRT sometimes can cause kind of a flare phenomenon, can make the tumor swell up a little bit before they start shrinking. And so we want to be mindful of that phenomena. So, if the patient is doing clinically well, for instance, if their carcinoid symptoms, their diarrhea is getting better and all that, then we wouldn't necessarily consider that true progression. We would kind of keep pushing forward and continue the 3rd and the 4th round. The other thing to consider is the comparison of the scan, what you're using as a baseline, right? So if you're comparing to a scan that was done a year ago, which sometimes we do the PET scans once a year, that may not necessarily mean that PRT is not working because PRT wasn't started until 4 months ago. So those are all things we have to keep in mind.
And then if somebody would be considered to have true progression, so not pseudoprogression or swelling of the tumors, is there, and I know it's probably on a case-by-case basis, but would you generally recommend to stop after 2 cycles, or would you?
So we have seen this in a minority of cases. We have seen patients whose tumors are growing so rapidly, and usually patients can have the associated symptoms too. They're not doing well, they're losing weight and things like that. Sometimes if it's out of proportion to what we expect, we may send them to get a repeat biopsy. And sometimes I've seen on cases like this, when they have dramatic progression through PRT, when we do the rebiopsy, they actually have a poorly differentiated neuroendocrine carcinoma clone that was emerging, for which the PRT was not the right treatment, so they need to be on chemotherapy.
Great, thank you very much. So one of the questions here, it's kind of a surgical question, but I'm going to ask it to you because I know you love surgeons so much. So the patient says here, if you have 4 or 5 small, less than 1 centimeter lesions in the liver that are metastasized from a small intestinal neuroendocrine tumor, would you, as an oncologist, ever send these patients to surgery, or would you consider continuing another therapy or starting another therapy, or is there generally a sort of a threshold of when you send patients to surgery?
Well, and I do have soft corner for surgery. In fact, my first neuroendocrine tumor project paper and presentation was SSO. I have a soft corner because I have seen, I think surgical site reduction debulking can make a lot of difference in patients, definitely in a functional NET patients. In non-functional NET patients, absolutely. If you have a good surgeon, you have a good debulking, 90+%, and for sure. The usual critique is lack of prospective randomized data with proven outcomes. In cancer world, we are pretty tough on ourselves. We really want to show overall survival benefit. In disease like NETs, this is difficult to show. And the next best step is surrogates like progression-free survival, etc. And unfortunately, we don't have that. So that's where this whole debate between surgeon and medical oncologists and others come up. Hey, are we selecting a good patient? We will have done regardless very good, right? I was at a meeting with Dr. Fisher recently. He showed me a patient with metastatic disease. And this patient with metastatic disease had completely stable disease for 13 years with no treatment at all. Didn't need a medical oncologist, didn't need a surgeon, right? So we really have to individualize the treatment. That's the uniqueness of neuroendocrine tumor, right? So the key here is biology. I would trend the biology first. If it's going to declare itself, it's going to be more lesion in the near future, waiting for a surgery is probably a good idea. You don't want to subject a patient to surgery and then 3 months later, there are new lesions. At the same time, if it's a more indolent cancer, for sure, I'm going to always ask my surgeons or my colleagues, hey, this patient is otherwise relatively low bulk cancer, and we are looking at very good long-term prognosis. Can we cytoreduce? There is data to support, like yours and several other prominent surgeons, that certain patients can certainly benefit. So I don't think there's a cookie cutter answer. And that's where I feel people like us have a job security, because it's not easy. We have to really individualize cancer based on individual patients, prognostic factors, tumor growth rate, the grade of the disease, burden of disease. And this is especially for non-functional patients. For functional NET patients, yes, I'm more liberal in sending them for cytoreductive surgery early on, because taking as much tumor out certainly can help them in the short interval for symptom management at least.
Yeah, thank you very much. I think this is, it's a good answer from a non-surgeon even. I really appreciate it. I think in this particular case, with 4 or 5 small, less than 1 centimeter neuroendocrine tumors in the liver, I would agree with you. I don't think surgery is necessarily the best way moving forward for 2 reasons. Number one, like you said, biology, right? It's important to understand. So you could either not treat them or maybe start them on octreotide, especially if they are symptomatic, sort of see what happens. But also the bang for your buck, right? Because like you said, generally surgery, it's still surgery. It's, debulking surgery is a lot of surgery. You have to recover from it. And certainly going in there to remove 7-millimeter lesions is probably not worth a surgical operation, because, it can be done at a later time point when the liver tumor burden is higher. So there really is, I think, in my experience, a sweet spot of not waiting too long until the liver tumor burden is so high that debulking is off the table, and also not going in too early where, ultimately, what are you really going to achieve? You have a big surgery to remove 4 really tiny tumors, micrometastatic disease is going to be growing over time and show up again on the scan. So I think these are really different consideration, and like you said, very well on a case-by-case basis need to be considered. So that's it for us. But I have a last question for Anna, and that question is, how do you feel NETRF research has impacted the change of treatments in the neuroendocrine tumor world over the last 5 years?
Yeah, so we play a large role in funding research in this space. And, I've heard from a lot of the talks today, people would follow up and say, well, more research is needed. And we agree. We think there's a long way to go to, greatly improve how we early detect these tumors, how we treat them in a more precise manner, and how we can cure them, right, through treatments instead of stabilize them. And so NETRF plays a role in funding research in all of these spaces. But in terms of the last 5 years, I think we're really excited about these targeted treatments that have come onto the market. We're really excited about CAR-T therapy, which we've funded for the past decade and is now in clinical trials. So we're excited to see what comes from that. And so we feel very hopeful that we're going to get to a place where patients have even better outcomes than they do today.
Thank you so much. And this ties in together nicely with the topic of the conference, which was hope. I think we can all agree on this call that hope is probably the most important thing for our patients, but also for us. I think we do this because we are hopeful that our patients are going to do well, and we are hopeful that one day I can stop doing surgery, Dr. Chauhan can, retire to a nice island in Florida. Dr. Soares can go skiing every day. And then Dr. Liao, I know Andy very well, so he loves eating at good restaurants and traveling. So Andy can travel the world and eat at good restaurants. So we are very grateful that you were here with us today. Thank you so much for taking the time to prepare this conference. There's a lot of work that goes into this conference. We are very grateful that you took the time on a weekend also to be with us. So again, thank you very much. And we hope to see you next year for another conference.
Thank you so much. Thanks, Dr. Keutgen.
Thank you.
The team of NETRF. Thanks.
Thank you.
Thank you.
Thank you for attending Know Your Nets and spending this time with us. We hope you've learned a lot and enjoyed the program. Thank you to all our presenters who gave their time and expertise. And a special thank you to our Thrivers who shared their stories and valuable advice. Know Your Nets is possible because of support from our co-sponsor, University of Chicago Medicine, and all our sponsors, Novartis, RayzeBio, and Crinetics. Thank you. I want to recognize our NETRF team. This is a team effort with special thanks to Jessica Thomas, Jennifer Long, and Christine Coffey for the tremendous work to bring all of you Know Your Nets. If you missed any parts of the program or want to watch it again, we will be posting the program on our YouTube channel. You'll also be receiving a survey in the next few days. We'd love feedback, positive and negative, so let us know what you learned and what else we should include in future programs. If this program has been helpful to you, please consider supporting NETRF. We depend on community support to provide our educational resources. You can visit our Net Knowledge Center at netrf.org for more information on our guide, our podcasts, videos, and other online content. Thank you so much for joining us. Remember, NETRF is here for you. You're not alone in this journey, so take care, have hope, and thrive.